Thank you, everybody. And we are now returning to our ACIP meeting for the respiratory viral vaccine session, Pediatric Maternal, with an introduction by Dr. Sarah Long, who is chair of the work group.
Good afternoon. I am delighted to bring you the work group deliberations on this topic, and we very much want ACIP members' opinions and some directives. So fasten your seat. Next slide, please. So the ACIP members on this work group are right here in this corner of the room. We've got California, we've got Ohio, and Massachusetts. The consultants, we have several, as you see, very recognizable names as experts in respiratory syncytial virus, as well as opinion leaders. And we have obstetricians, statisticians, representatives that are very important from our liaison groups. Next slide, please. I keep trying to push my microphone to advance the slide. And we are blessed with two wonderful CDC leads in our work group, Catherine Fleming-Dutra and Dr. Jefferson Jones, both doctors. And the next three people have been very important: Meredith McMorrow, Mila Prill, and Natalie Thornburg, in helping us understand RSV policy, immunology, et cetera, et cetera. So we are at no loss for expertise, but we still need very much your opinions. Next slide, please. So you will remember that we have presented here previously the epidemiology and burden of RSV disease in infants, virology and immunology of RSV, and then several things related to the monoclonal antibody nirsevimab, which is a long-acting monoclonal antibody, both safety and efficacy, cost-effectiveness analysis from a CDC model, as well as comparisons with the manufacturer's model, and the evidence to recommendations framework for nirsevimab, as well as clinical considerations. Nirsevimab has been reviewed. The biologic license application has been reviewed by the Antimicrobial Drugs Advisory Committee of the Center for Drug Evaluation and Research, AMDEC of CDER of the FDA just 2 weeks ago, and there will be action on this in the next 3 months by the FDA. And today we're going to focus more on the safety and efficacy of Pfizer's RSV bivalent pre-fusion maternal vaccine. That's biologic license application was reviewed by VRPAC and of CBER and FDA, and was unanimously agreed on its benefits, and voted with some dissenters on its safety. So we will be thinking about those things as we review the new materials for today. Next slide, please. So the agenda today is the economic analysis of the RSVpreF in pediatric population, economic analysis of maternal vaccination on the pediatric populations by our colleague David Hutton at the University of Michigan, partner with the with the CDC on this. Evidence to recommendations framework by Dr. Catherine Fleming-Dutra. Economics of combined use of the vaccine and nirsevimab, again by Dr. David Hutton. And then clinical considerations by Dr. Jefferson Jones. That is all I have to say about this.
Thank you, Dr. Long. We'll move on to the presentation by Dr. Hutton from University of Michigan.
Thank you. Good afternoon. I'm happy to share the results of our economic analysis of the RSVpreF maternal vaccine. Next slide. like to acknowledge our research team, which includes collaborators from the University of Michigan and CDC, many of whom have extensive RSV expertise. And this is continuation of work we've been working on for the last several years. Next slide. None of us have any conflicts of interest to report. Next slide. Our overall goal here was to evaluate the cost effectiveness of the RSVpreF maternal vaccine. We're examining outcomes of resource utilization, cases, costs, deaths, and quality-adjusted life years lost from RSV. In the end, we want to compare the incremental cost-effectiveness ratio of using the RSVpreF maternal vaccine versus no vaccine and explore some scenario analyses to examine key areas of uncertainty related to these questions. In the end, we're taking a societal perspective in this analysis. Next slide. So we're examining a US population of pregnant persons, comparing RSVpreF to no RSVpreF, which I may occasionally refer to as natural history. This is in contrast to what I'll present in a little bit later on this afternoon. So this one is just looking at RSVpreF versus natural history. We're looking at RSVpref's impact on RSV over one RSV season, but we're going to use a lifetime analytical horizon to look at the outcomes that might last beyond that year, like years of life lost due to deaths. And we're discounting those long-term outcomes by 3% per year. Next slide. In order to conduct this analysis, we're using a decision tree model, which is similar to the one, if you listened to me yesterday, you would have seen as well. This decision tree incorporates several parts to it. The top shows what happens without the vaccine. With no vaccine, individuals can become infected, maybe get hospitalized, have an ED visit, outpatient visit, or none of the above. Children who are hospitalized can die. The bottom of the tree, we include outcomes related to RSVpreF. So there might be several adverse events. And then after that, there can be infection events, and presumably the likelihood of those RSV outcomes are lower with RSVpreF. So with this, we can calculate all those events, cost, quality adjusted life years, number needed to vaccinate, and so forth, and cost per quality adjusted life year gained. Just want to highlight again, this is a decision tree model, so it does not take into any reductions in RSV transmission. So these results are not really dependent on uptake. We don't take into account infections that are not medically attended. Next slide. So I want to focus first on the epidemiology of RSV. All these these RSV epidemiological assumptions I'm going to show in the next 4 slides are identical to what you saw in my February presentation on the RSV epidemiology for nirsevimab. This slide shows our estimates of RSV hospitalization incidents. They come from the CDC New Vaccine Surveillance Network in seasons 2016 through 2020. We can see the rates are higher for the younger age groups and then drop in older children. In our base case, we assume RSVpreF only reduces lower respiratory tract infections. So we have to make an assumption here then about how many of these visits are due to lower respiratory tract infections. And in this case, we're going to assume 100% of hospitalizations are from lower respiratory tract infections based on a study by Renish et al. Next slide. So this slide here shows the information on incidence of emergency department and outpatient visits. The top section shows emergency visits per 10,000 children, or sorry, 100,000 children. And rates are highest for the youngest age groups and drops as they get older. These rates come from a study by Lively, Hall, and Jackson. You can also see in this table, we have to make some assumptions about the proportion of these ED and outpatient visits that are due to lower respiratory tract infections. These estimates also come from a study by Renish et al., but they're not 100%. They're a little bit lower than that. Okay, next slide. In our model, mortality is also linked to hospitalization, and this slide shows our estimates of our RSV mortality given that someone is hospitalized. Next slide. The model incorporates information in monthly time periods to track incidence over time, including seasonality here, and including the timing of RSVpreF administration to track waning protection over time. So this is showing seasonality. It's coming from the National Respiratory and Enteric Virus Surveillance System from 2015 through 2019. Next slide. This graph here now starts to show some new information here, showing how we model efficacy starting high and dropping over time. We've got 2 lines on here, one for against hospitalization on top, and then the next one is for against medically attended RSV-associated lower respiratory tract infection for outpatient visits here. So the average, this dropping over time, the average efficacy in those first 6 months is equivalent to the efficacy observed in the trial. And then we assume the efficacy drops to 0 after the first 6 months. In the next slide, we're showing an alternative scenario where efficacy is flat during those first 6 months, and that's exactly equivalent to the trial efficacy, and then drops to 0 after that. Next slide. So here are the precise estimates or numbers, sorry, for the efficacy assumptions. So we have the efficacy against medically attended RSV-associated lower respiratory tract infections of 51.3% based on the phase 3 trial, and then efficacy against hospitalized RSV-associated lower respiratory tract infections is 56.8%. And again, we assume 0% efficacy against upper respiratory tract infections, but we'll vary that in sensitivity analysis. Next slide. Okay, so see here. We also want to include some adverse events due to the intervention here. So I want to talk about the provision of RSVpreF here. In the base case, we're assuming that it's given year round, but we have some scenarios here where it might be additional scenarios where we might look at RSVpreF only given to children born at certain times of the year. Next slide. And we're assuming that the vaccine is given to the mother during weeks 24 through 36 weeks of gestation based on the distribution of Tdap vaccination by week in that time period. Also, we're assuming that the vaccine is given, but it must be given at least 2 weeks after the the birth must occur 2 weeks or more after vaccination for the protective efficacy to pass to the infant based on the historical gestational age. Next slide. So, for example, if we have 100 pregnant persons, we're assuming 50% uptake, so only 50 would be vaccinated. The other 50 would choose not to get vaccinated. And then based on the timing of when the pregnant person would get vaccinated and when the birth might occur, 3 individuals might not get vaccinated in time. The birth might be too early for the vaccination protective efficacy to take into effect, but the other 47 would be vaccinated in time. Next slide. Okay, so here we have some information on medical costs. These are disease-specific hospitalization costs and ED costs and outpatient costs based on a study by Bowser, a systematic review of studies of medical costs. Next slide. We also include productivity costs, and this slide includes time of days lost productivity for parents if their child gets RSV, whether it's outpatient, ED, or hospitalized. And then we have lifetime productivity losses for deaths. Next slide. Here we have the intervention costs. We are assuming an RSVpreF cost per dose of $200, but we vary that between $50 and $300. And we also include RSVpreF administration costs. Next slide. We also include adverse event costs due to the intervention. This slide here shows parameters related to injection site reactions and hypothetical serious adverse events. Next slide. Of course, those I just showed you some adverse events, that would be mainly affecting the maternal recipients of the vaccine, but a bigger concern is prematurity. The clinical trial results suggest that there may be an increased rate of prematurity associated with the vaccine. The confidence interval, though, that you can see roughly on here, it shows that the confidence intervals overlap. So there might be no increased risk, but there also could be maybe a 1 or even 2% increased risk as well. So we really want to explore this in sensitivity analysis to really understand the potential impact of prematurity on the cost-effectiveness results. Next slide. So for our base case, we're going to assume no increased prematurity with RSVpreF. However, we're going to vary this from 0 to 2% increase in prematurity in sensitivity analysis. The bottom of this table shows the assumptions about costs and quality of life lost if there is an increase in prematurity. Next slide. We also include quality of life lost due to RSV. These assumptions here are identical to what you saw in my February presentation on nirsevimab. The table shows quality adjusted life years lost due to RSV, not only for the child, but for the caregiver. We have different levels of quality adjusted life years lost for outpatient, ED, and hospitalization visits. This table is showing quality of life lost in terms of quality adjusted life days, but we do convert that days by dividing by 365 to convert it into quality adjusted life years. I want to highlight also there's quite a bit of uncertainty surrounding these quality adjusted life years lost from RSV, so we have wide ranges in sensitivity analysis. Next slide. So in addition to our base case results, we're going to conduct several sensitivity analyses to evaluate uncertainty. We conducted one-way sensitivity analysis where we vary each parameter individually. Then we ran some scenario analyses. In the first one, we examined what RSVpreF, what if RSVpreF has increased prematurity, what the results might look like. We also examined different costs of RSVpreF. We examined different scenarios about timing of administration of the vaccine. We examined scenarios where RSVpreF also reduced upper respiratory tract infections to the same extent that it reduces lower respiratory tract infections. And the final scenario analysis we looked at was on that alternative assumption about waning efficacy where it's flat and then drops to 0. So now let's look at the results in the next slide. Our results start off with a base case where we look at a hypothetical cohort of 1,000 births and we assume 50% uptake in the RSVpreF group. We're looking at the first RSV season, again, assuming $200 dose cost per dose, and assuming that RSVpreF only impacts lower respiratory tract infections. So in the next slide are the resulting health outcomes with natural history and with RSVpreF. This graph shows the number of events that would occur over one RSV season. The light blue bars show upper respiratory tract infections, and the darker blue is lower respiratory tract infections. You can see the darker blue lower respiratory tract infections are reducing with RSVpreF, and the upper respiratory tract infections, the light blue bars, are not shrinking because we assumed RSVpreF has no impact on upper respiratory tract infections. Next slide shows the events averted with RSVpreF per 1,000 births. We show outpatient visits, ED visits, inpatient visits, ICU stays, inpatient days, and ICU days. On the next slide, we can look at the results in terms of number needed to vaccinate to avoid one of these events. For example, 234 people would need to be prophylaxed or vaccinated to avoid one inpatient stay. Next slide. So this figure here shows costs. It has a lot of information on it. Each different subsection here is a different cost category. And then within that, we show natural history and RSVpreF bars. The different colored bars here represent different types of costs. The light blue bars represent medical costs, and the dark blue bars represent productivity costs. Here we see that RSVpreF has higher intervention costs and slightly lower cost of disease. But in the end, the last bars in the far right, we see higher overall cost of RSVpreF, meaning RSVpreF is not expected to pay for itself in terms of reduced RSV disease costs. Of course, we don't just care about costs, and on the next slide, we'll see health outcomes. In this figure, we see the net cost per event averted. This is the net cost, including cost savings from averting these events. We can see in the center of this figure, for example, with RSVpreF, we're paying a net cost of $32,945 per inpatient event averted. Next slide. So here are the quality adjusted life years lost for a population of 1,000 births with 50% uptake. With RSVpreF, we lose 0.0001 quality adjusted life years due to adverse events, but we lose far fewer qualities overall with RSVpreF as compared to natural history because of averted RSV outcomes and impacts to the children and their caregivers. Overall, natural history loses 4.73 quality adjusted life years, whereas the RSVpreF strategy only loses 4.42 quality adjusted life years. So fewer quality adjusted life years lost. Next slide. This next table here shows the overall cost effectiveness summary measures. Overall, the RSVpreF strategy has an incremental cost effectiveness ratio of $214,087 per quality adjusted life year gained compared to the natural history. Next, I'd like to show you our sensitivity analyses. Because this is a new product, we're uncertain about many things. This graph shows how the top 10 most influential parameter assumptions affect the cost effectiveness of RSVpreF. On the left-hand side, you can see the individual parameter names, and the colored bars in the middle show how each parameter can affect the incremental cost effectiveness ratio. Recall that the base case incremental cost effectiveness ratio is $214,000 per quality adjusted life year gained. The light blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter is lower, and the dark blue portion of the bar represents how the incremental cost effectiveness ratio would change if the parameter is higher. As you look at the top bar, you can see how prematurity affects the results. If RSVpreF increases prematurity by up to 2%, the incremental cost effectiveness ratio would skyrocket to over $14 million per quality adjusted life year gained. Other important parameters here are related to RSV disease costs, quality adjusted life years lost from RSV, vaccine efficacy, and vaccine cost. Okay, next slide. The first important parameter here is increased risk of prematurity. You can see that even a very small increase in prematurity risk can dramatically increase the incremental cost-effectiveness ratio. Next slide. Cost is also important. Here's a graph showing how the incremental cost-effectiveness ratio varies as the cost of RSVpreF changes. The blue dot shows our initial assumption of $200 per dose, but if it were more expensive, then the incremental cost-effectiveness ratio would rise. And of course, if RSVpreF were cheaper, the incremental cost-effectiveness ratio would drop, potentially even to being cost-saving if the cost per dose dropped substantially. Next slide. As I mentioned, we examined some additional scenarios related to RSVpreF timing. In our base case, we assumed that RSVpreF would be given year-round, but we explored a few additional scenarios shown here where the vaccine could be administered strategically to try to make sure infants born only during the peak of RSV season would be protected. So on the next slide here, we can show the results of the scenario analysis. We see that if the vaccine timing were focused to be administered only during certain months, like June through February on the far right bar, the cost would be lowered without impacting efficacy very much, and we could see a more favorable cost-effectiveness ratio. The next graph on the next slide here shows the impact of if RSVpreF also reduces upper respiratory tract infections. In our model, we assume many of the outpatient and ED visits are caused by upper respiratory tract infections. So this sensitivity analysis assumes RSVpreF would avert more of those outpatient and ED visits to the same extent that it reduces lower respiratory tract infections. If RSVpreF also reduces these upper respiratory tract infections to the same extent as it does for lower respiratory tract infections, it would lower their cost-effectiveness ratio. In this scenario, the incremental cost-effectiveness ratio would drop to $153,674 per quality adjusted life year gained if RSVpreF costs $200 per dose. Next slide. The final scenario I'd like to show is one where we assume efficacy is flat during those 6 months after birth, instead of starting lower and slowly declining, but it still declines to 0 at 6 months. In this scenario, the incremental cost-effectiveness ratio declines slightly to $191,749 per quality adjusted life year gained. Next slide. I'd like to point out some limitations of our analysis. The model structure does not contain varying risk groups besides age. The model also does not include dynamic transmission, so we assume RSVpreF does not reduce any kind of population transmission of RSV. Additionally, models like this are a function of the underlying parameter assumptions. We have many uncertain inputs. We're uncertain what the actual RSVpreF costs will be for payers. We don't have great information on quality of life lost with RSV in this population. And we don't know if it might reduce upper respiratory tract infections. And we lack good data on the risks of prematurity. Next slide. So in summary, RSVpreF may improve RSV outcomes, but it also comes with high costs. The cost effectiveness of RSVpreF depends on many factors, particularly the rates of prematurity. The cost per dose could also cause the incremental cost-effectiveness ratio to vary between being cost-saving to about $350,000 per quality adjusted life year gained. RSVpreF efficacy, particularly against upper respiratory tract infections, could cause the incremental cost-effectiveness ratio to vary between roughly $150,000 and $350,000 per quality adjusted life year gained. Finally, variations in the quality of life with RSV for both children and their caregivers could cause the incremental cost-effectiveness ratio to vary between $50,000 and almost $500,000 per quality adjusted life year gained. So under certain conditions, RSVpreF might be more cost-effective, and under other conditions, it might look very expensive. And with that, I want to thank you, and we'll go to the next slide here. I'm happy to answer any questions you might have.
Thank you, Dr. Hutton. This presentation is now open for questions. Oh, Dr. Paling.
First of all, thank you, Dr. Hutton, for you and your team for creating a very clear presentation to understand the cost-effectiveness analysis and highlighting the uncertainty related to prematurity, which is really important. I'm going to ask a question if the framework should be expanded. And what I'm thinking of is we are vaccinating the mom during pregnancy. And we know that viral infections during pregnancy are not good for you and can be associated with morbidity themselves. And we know from flu that flu can cause prematurity itself. And so is there a potential that RSV would be associated with prematurity? And should we explore the impacts on the pregnant mom as well?
That's a great question, and you're great to highlight. We did not look at outcomes to the mother, so we don't look at the benefits to the mother from having some protection from this vaccine. And I will say I'm not an expert in the relationship between RSV and prematurity, but that would, if giving the vaccine would reduce rates of prematurity, that would certainly make the vaccine RSVpreF look better, much better. Yeah. So that's something we can consider for future analyses.
Yes, and this
Dr.
is,
Dutra will comment on this.
yes, thank you. Thank you for that great question. The reason that we did not include it in this model is because the trial itself did not assess efficacy in maternal participants. And as far as we know, there is not an association between RSV infection and pregnancy and prematurity, although I will note that the data on RSV epidemiology in pregnant persons is incredibly limited.
May I advocate that future studies of vaccines in pregnant women should include outcomes for both the mother and the child in the future? Thank you.
I think that certainly makes sense. We did see data on the outcomes of RSV, what we could find in pregnant women, and could not make a case that a vaccine would alter outcome in pregnant women in a beneficial way. But you're right.
Other questions? Ms. Bata?
I'm going to dig deeper here, trying to understand how the mother's outcome wouldn't be monitored. I mean, a fever from vaccine might prompt the pregnant woman to take Tylenol. There's concerns about Tylenol during pregnancy. So I don't know how you can ignore the outcomes from vaccination.
And excuse me if I misspoke, the efficacy in pregnant persons was not tracked in the trial. Safety was tracked, and we'll
okay.
go through that in EtR as well. But safety was tracked both in the pregnant people and in infants.
Okay, thank you.
Dr. Sanchez?
Well, I just wanted to add that we reviewed the available data and there's obstetricians on the call as well in the work group, and from available data, RSV infection has not been shown to have adverse effects on the pregnancy. We certainly, the study did monitor the effects and actually the rates of prematurity, which many of them occurred after 42 days after the vaccine. So, yeah. So I think we're looking at a vaccine similar to pertussis, which is going to be neonatal outcome rather than pregnancy outcomes such as flu, as influenza.
So it is different from influenza in that regard.
Just to clarify, Dr. Long, you mean it behaves differently than influenza, or is it also plausible that we just, RSV is an old disease, but it feels like a new disease this meeting, in that there's still a lot of underlying epidemiology that's worth exploring. So I'm just wondering, is it worth exploring, or do you feel clinically that it's different and doesn't deserve further exploration?
There just are no data that RSV affects pregnancy, the woman or the pregnancy outcome, in any adverse way. There are plenty of data that influenza does that. And you might even make a very small case for pertussis, but this is more like pertussis, even more so that we do not feel that we can make a case for giving RSV vaccine to mothers to protect the mothers from any outcome.
So, Dr. Chen, and then I realize we veered off course from poor Dr. Hutton's presentation. So I just want to clarify if there's any questions for Dr. Hutton specifically.
Yeah, I might have missed, what was the assumption behind the 50% uptake in vaccination? And was there any looking around other assumptions higher numbers or lower numbers, and how did that affect?
Yeah, I mean, I think we're on, uptake of other vaccines is not great, and to be honest, 50% is kind of a round number. So we use that. With that said, the uptake actually doesn't affect the cost effectiveness ratios. It does affect the total magnitude of impact and in population wide. If 0% uptake, you're going to get 0% of the benefit. If it's 100%, you're going to get more benefit across the population, but of course higher costs. So the cost effectiveness ratio doesn't change, but some of the total population outcomes like numbers of events averted in the entire population might change. But so we actually didn't explore varying that because the cost effectiveness ratio in the end wouldn't be affected.
Great, thank you. And then just one general question is, typically we're looking at one population or the other, and this clearly focused on the infant in the model. Are there ways to consider exploring dyadic models and incorporate both maternal and infant outcomes?
So it certainly is possible, and actually to some extent we do in the quality adjusted life years lost from adverse events. That does include quality adjusted life years lost to the maternal part of that dyad. As it was mentioned earlier, since the trial didn't track the maternal outcomes, really due to reduced RSV and improved quality of life, maybe from reduced RSV in the maternal participants, we didn't include that. But certainly, there's nothing theoretically that would limit us from looking at this from the perspective of a dyad of the mother and the child. It's just that we don't have great data on that. But were that data to come out in the future, that's something we could potentially look at.
Thank you. Are there any other questions for Dr. Hutton? Thank you, Dr. Hutton, for a clear presentation and your, I think, double or triple duty today. We'll move on to the presentation by Dr. Fleming-Dutra, Evidence to Recommendations Framework for the Pfizer RSVpreF vaccine.
Good afternoon. Next. So the policy question under consideration today is, should vaccination with Pfizer RSVpreF vaccine, which contains 120 micrograms of antigen, administered as a single intramuscular dose given between 24 through 36 weeks gestation, be recommended for pregnant people to prevent RSV disease in infants? Next. For the PICO question, the population is pregnant people between 24 through 36 weeks gestation. The intervention is Pfizer RSVpreF vaccine. The comparison is no vaccine or intervention, which is the current standard of care for the prevention of RSV disease in most infants, and the outcomes chosen by the work group are listed here. Next slide. The EtR framework includes the following domains. Next. The first domain is public health problem, and I will note that data on the burden of RSV disease in infants has been previously presented to this committee by Dr. McMorrow last June, so in the interest of time, I'll be brief in this section. Next. RSV infection is the leading cause of hospitalization in U.S. infants. Most infants are infected in the first year of life, and nearly all by age 2 years. And 2 to 3% of young infants will be hospitalized for RSV. RSV is a common cause of lower respiratory tract infection in infants, which is what leads infants to be hospitalized. The highest RSV hospitalization rates occur in the first months of life, and risk declines with increasing age and early childhood. An estimated 79% of children hospitalized with RSV aged less than 2 years had no underlying medical conditions. So in short, all young infants are at risk of severe disease with RSV. Next. The CDC's National Respiratory and Enteric Virus Surveillance System, or NERVS, is our primary source for monitoring RSV seasonality in the U.S. This graph shows the percent of RSV PCR tests that were positive pre-pandemic during the 2017 to 2020 seasons, and shows that RSV transmission followed a consistent seasonal pattern with peaks during December to February, which is the typical RSV seasonality that has been observed in the United States for years. Next. Now we can layer on top the pandemic-era RSV seasons, shown in the dashed orange for 2020 to 21, yellow for 2021 to 22, and red for the 2022 to 23 seasons. And we can see that the COVID-19 pandemic disrupted RSV seasonality. Also, we can see that the 22 to 23 season in red began later than the 21 to 22 season in yellow, but earlier than the pre-pandemic seasons in blue, suggesting an incremental return toward pre-pandemic seasonality with winter peaks, although we'll have to see if this pattern continues. Next. So when asked, is RSV among infants of public health importance, the work group unanimously responded yes. Next. Now for our second domain, benefits and harms. Next. Here are the outcomes, their importance, and the data sources used for grade for this vaccine. Of these 11 outcomes, at present we have data for 8 of them. Data were available from 2 trials, Pfizer's phase 3 trial and an earlier phase 2b trial in pregnant people. Next. Here is a summary of the efficacy estimates and concerns and certainty of assessments for the benefits for this vaccine. For medically attended RSV-associated lower respiratory tract infection in infants, which was a critical outcome, we had data from the phase 3 trial. Vaccine efficacy was 51.3% from 0 through 180 days of life, and there were no concerns in the certainty assessment. For hospitalization for RSV-associated lower respiratory tract infection in infants, also a critical outcome, data were available from the phase 3 trial, and the efficacy was 56.8% with serious concern for imprecision. No data were available for the critical outcomes of ICU admission or mechanical ventilation. For RSV-associated death in infants, an important outcome, there were data from both trials in which there was 1 RSV-associated death among an infant in the placebo arm of the phase 3 trial that was recorded at day 120 after birth. For the important outcome of all-cause medically attended lower respiratory tract infection in infants, there were data from the phase 3 trial showing an efficacy of 2.5% with serious concern for imprecision. And for the important outcome of all-cause hospitalization for lower respiratory tract infection in infants, there were no data. Next. So now let's talk about the certainty of assessment for harms. For the critical outcome of serious adverse events in pregnant people, data from the phase 3 and phase 2b trial showed a relative risk of 1.06 with serious concern for imprecision. For the important outcome of reactogenicity of grade 3 or higher in pregnant people, data from the phase 3 and phase 2b trials showed a relative risk of 0.97, and there was serious concern for indirectness as this only includes systemic but not local reactions. For the critical outcome of serious adverse events in infants, data from the phase 3 and phase 2b trials showed a relative risk of 1.01 with serious concern for imprecision. And for the critical outcome of preterm birth, meaning less than 37 weeks gestation, data from the phase 3 and phase 2b trials showed a relative risk of 1.20 with a 95% confidence interval of 0.99 to 1.46 with very serious concern for imprecision. Next. So overall, the summary of GRADE showed that the Pfizer RSVpreF maternal vaccine is effective in preventing medically attended RSV-associated lower respiratory tract infection in infants with a high certainty in the evidence. This vaccine may be effective in preventing hospitalization for RSV-associated lower respiratory tract infection in infants with moderate certainty. The vaccine is not effective in preventing all-cause medically attended lower respiratory tract infection in infants with moderate certainty. Serious adverse events in pregnant people were balanced between the vaccine and placebo groups with moderate certainty. Reactogenicity in pregnant people was balanced between the vaccine and placebo groups with moderate certainty. Serious adverse events in infants were balanced between the vaccine and placebo groups with moderate certainty. And preterm births were unbalanced between vaccine and placebo groups with low certainty in the evidence. Next. So this results in an overall evidence type of low. Next. So I want to take a few minutes to discuss the outcome of preterm births in more detail. Shown here are the preterm birth rates for these 2 trials by less than 34 weeks gestation and less than 37 weeks gestation, which are highlighted in the red boxes. In the phase 3 trial, there were 201 preterm births less than 37 weeks in the vaccine arm compared to 169 in the placebo arm. In the phase 2b trial, there were 6 preterm births less than 37 weeks out of 115 births in the vaccine arm, compared to 3 out of 117 births in the placebo arm. In the meta-analysis of these data performed for GRADE, this resulted in a relative risk of 1.20 with a 95% confidence interval of 0.99 to 1.46. Next. So this slide shows the summary of the GRADE assessment for the outcome of preterm birth. Again, here's the relative risk. And the absolute risk reduction was 9 more per 1,000 with a 95% confidence interval from 0 fewer to 22 more. For this outcome, we had very serious concern for imprecision due to the width of the confidence interval containing estimates for which different policy decisions for recommending this vaccine might be considered, and not meeting optimal information size requirements. The final certainty of the evidence for this outcome was rated as low. Next. The work group chose preterm birth as a critical outcome because a trial of a similar GSK maternal RSV vaccine, also a stabilized prefusion F protein vaccine, was halted due to an imbalance of preterm births in the vaccinated compared to placebo groups. In that trial, the preterm birth rate was 6.81% in the vaccine arm versus 4.95% in the placebo arm, and the difference was statistically significant. There was also an imbalance in neonatal deaths, which was determined to be a consequence of the preterm birth imbalance. The imbalance in preterm birth was seen in low and middle income countries, but not in high income countries. And the imbalance was observed from April through December 2021, but not consistently after December 2021. And the reason for the imbalance in preterm births in the GSK trial remains unclear. Next. There was also another similar vaccine, the Novavax maternal RSV vaccine, which had a phase 3 clinical trial with 4,600 pregnant women. The Novavax vaccine was an RSVpreF protein nanoparticle vaccine, which was adjuvanted but was not stabilized in the prefusion form. This maternal vaccine did not reach primary efficacy endpoints and thus did not move forward. However, there were no safety concerns in this trial. And in the Novavax trial, 5.9% of infants in the vaccine group were born preterm compared to 6.2% in the placebo group. Next. So now returning back to the Pfizer RSVpreF vaccine trial data, in the phase 3 trial, preterm birth, less than 37 weeks gestation, occurred in 5.7% of infants in the vaccine group versus 4.7% in the placebo group. However, this 1% difference was not statistically significant because the 95% confidence intervals of the point estimates overlap. Late preterm births, meaning from 34 to less than 37 weeks, occurred in 5% of births in the vaccine group versus 4.4% in the placebo group. And low birth weight, defined as less than or equal to 2,500 grams, occurred in 5.1% of the vaccine group versus 4.4% in the placebo group. Next. The GSK trial again observed an imbalance in neonatal deaths occurring as complications of prematurity. However, in the Pfizer trial, when looking at all-cause infant mortality through 24 months of age, there were 5 or 0.1% deaths in the RSVpreF group versus 12 or 0.3% in the placebo group. Among infant deaths in the RSVpreF group, 4 of 5 deaths were considered unrelated by FDA. However, 1 death was in an infant with extreme prematurity and prematurity-related complications, and FDA was unable to exclude the possibility of relationship to the investigational product. Next. This table shows time from vaccination to birth among preterm and term infants in the phase 3 trial. It is important to note that the median gestational age at vaccination in the trial was 31 weeks. Among preterm deliveries, 5.5% in the vaccine group versus 7.7% in the placebo group were within 7 days of vaccination. 34% of preterm births in both groups occurred between 8 and 30 days after vaccination, and 60.2% of preterm births in the vaccine group versus 58% in the placebo group occurred more than 30 days after vaccination. Next. This slide shows gestational age at birth by country income level in the Pfizer trial, and found that in high-income countries, preterm births less than 37 weeks were balanced between the two groups at 5.1% in both arms, but imbalanced in upper middle income countries. Additionally, there was no imbalance in lower middle income or low income countries, but the numbers were small in those sites. Next. Specifically, when preterm birth was examined by country, one country, South Africa, had the highest imbalance, shown in this table, with an overall preterm birth rate of 8.3% in RSVpreF recipients compared to 4.0% in placebo recipients. Among U.S. participants, preterm birth occurred among 5.7% in RSVpreF recipients versus 5.3% in placebo recipients. Next. So VRPAC met on May 18th to discuss this vaccine, and that discussion regarding preterm births focused on several key points. A non-significant imbalance was seen in preterm births, but the imbalance was seen in both the phase 2b and phase 3 trials. The preterm birth rate in the trials was lower than the background incidence rate of preterm birth, which is about 10% in the US. But the trial had multiple exclusion criteria, selecting for a population at lower risk for preterm birth. Additionally, the trial was underpowered to detect a 20% relative increase in preterm birth. Next. On the other hand, the discussion at VRPAC also noted that the imbalance was still present, but less pronounced when comparing the prevalence of low birth weight, that most preterm births were late preterm at greater than or equal to 34 to less than 37 weeks, which some found reassuring. Most preterm births were more than 30 days after vaccination, and the preterm birth imbalance was most prominent in a single country, South Africa. VRPAC voted 14-0 that the data supported effectiveness of the Pfizer maternal RSVpreF vaccine, and 10-4 that the data supported safety. Next. Another potential safety consideration is inflammatory neurologic events. The Pfizer RSVpreF vaccine is the same vaccine, formulation, and dose that is approved for use in older adults. As you heard about yesterday, within the main phase 3 trial for this product, among adults ages 60 years and older, a potential neurologic safety signal was identified, and a total of 3 cases of potential inflammatory neurologic events was recorded among about 20,000 investigational vaccine recipients across all the clinical trials, and no cases were observed among placebo recipients. Next. However, we know that no Guillain-Barré and other demyelinating events were reported in the phase 2b or 3 trials among pregnant people. We also know that the background rate of Guillain-Barré syndrome in pregnant people is much lower than that among older adults. Guillain-Barré syndrome is rare among pregnant people, and during 2004 through 2015 in the Vaccine Safety Data Link, there was an incidence rate of 2.8 per million person years, which was based on 2 observed cases. Next. So when asked how substantial are the desirable anticipated effects of the Pfizer maternal RSVpreF vaccine, the work group responded that they were moderate to large. Next. And regarding the undesirable effects, the work group was split. The 2 most common responses were small and don't know. However, a minority chose moderate. Next. Sorry. And regarding the balance of desirable and undesirable effects, the work group was evenly split between favors intervention and unclear. And at the end of EtR, I will summarize the work group's interpretation around benefits and harms. Next. So now moving on to the third domain, values. The University of Iowa, RAND, and CDC worked together to conduct a value survey, which included 523 participants, of whom 58.1% were currently pregnant and 44.9% had given birth within the last 12 months. The distribution of participants by race and ethnicity are shown here. And 68% of respondents had knowledge of RSV prior to taking the survey. Next. In this survey, 61% of respondents said they definitely or probably would get an RSV vaccine while pregnant. Next. Among those who did not respond that they definitely would get an RSV vaccine while pregnant, safety concerns, lack of RSV knowledge, and concerns about vaccination causing or intensifying RSV infection were the top reasons for not wanting an RSV vaccine during pregnancy. Next. Additionally, when asked how many vaccines they would be willing to get in the same healthcare visit, 22% of respondents did not want any vaccines or were unsure about how many vaccines they would be willing to get during the same visit, during pregnancy. And furthermore, 17% said they would only be willing to receive 1 vaccine, 32% 2 vaccines, 9% 3 vaccines, and 20% 4 vaccines. Next. It's also important to note that in general, coverage for recommended vaccines among pregnant people is not high, varies by race and ethnicity, and has decreased during the pandemic. This graph shows Tdap vaccination coverage among pregnant women overall and by race and ethnicity from the Internet Panel Survey in the United States from April 2020 through April 2022. Overall, Tdap vaccination coverage was over 50% in 2019-20 and 2020-21, but fell below 44% in 21-22. and rates of Tdap coverage are higher in white non-Hispanic women than among Black non-Hispanic women. Next. When asked whether the work group felt that pregnant people feel that the desirable effects are large relative to the undesirable effects, they answered probably yes. Next. And when asked, is there important uncertainty about or variability in how much pregnant people value the main outcomes, the majority of the work group answered probably important uncertainty or variability, while a substantial minority answered probably not important uncertainty or variability. Next. Now moving on to acceptability, and of note, there are limited data to inform this domain. Next. A study in England assessed support of an RSV vaccine among maternity healthcare professionals, specifically obstetricians and midwives, if it was routinely recommended. And 47% definitely and 34% likely would support a routinely recommended RSV vaccine. Next. When asked, is RSV prevention with Pfizer maternal RSVpreF vaccine acceptable to key stakeholders, the majority of the work group answered probably yes or yes. Next. Moving on to feasibility. The storage and handling requirements are listed here. The Pfizer maternal RSVpreF vaccine is supplied as a single 0.5 milliliter dose or in packs of single-dose kits. Reconstitution is required, with reconstitution supplies included in the kit. The product should be refrigerated and protected from light, and after reconstitution, the product should be administered within 4 hours. Next. Regarding timing of RSVpreF vaccination during pregnancy, the trial dosing was between 24 and 36 weeks gestation, but the median gestational age at vaccination in the phase 3 trial was 31 weeks. Administration of maternal RSVpreF vaccine during regularly scheduled prenatal visits and bundling with recommended screening tests and other recommended vaccinations could improve feasibility. For example, Tdap is recommended every pregnancy, preferably during the early part of gestational weeks 27 through 36, and the glucose challenge test is recommended at 26 to 28 weeks gestation. Next. While the phase 3 trial was not powered to assess efficacy by gestational age at vaccination, in the interim analysis up to 120 days of life, shown in this table, significant efficacy against medically attended RSV-associated lower respiratory tract disease was seen among infants whose mothers were vaccinated between 28 to less than 32 and 32 to 36 weeks gestation. Efficacy was not significant for mothers vaccinated from 24 through 27 weeks, but the confidence intervals were very wide for this estimate, indicating that the estimate was not adequately powered. Next. RSV vaccine dosing could be implemented for pregnant people as a seasonal campaign or year-round. Year-round dosing would simplify implementation and thus potentially increase vaccine uptake and could also protect infants in the event of atypical RSV seasonality. However, as we've already heard, year-round dosing is less cost-effective than seasonal dosing. Additionally, there is limited benefit for doses given during March through May, which changes the benefit-risk calculation for doses administered in that timeframe. Next. Additionally, some U.S. jurisdictions have different or less predictable RSV seasonality, and recommendations for RSV vaccine dosing in those jurisdictions would need to account for that. These jurisdictions include those with tropical climates, parts of Florida, Puerto Rico, U.S. Virgin Islands, Hawaii, Guam, and the U.S.-affiliated Pacific Islands, and Alaska. Next. Pregnant people may be potentially eligible to receive RSV, Tdap, COVID-19, and influenza vaccines at the same visit. There are no data available on simultaneous administration of RSVpreF vaccine in pregnant people and only limited data in non-pregnant people. According to CDC's immunization general best practices, age-appropriate vaccinations can be administered simultaneously with 2 specific exceptions detailed in the footnotes. Next. There was a Pfizer phase 2b study in healthy non-pregnant women ages 18 to 49 on co-administration of Tdap and Pfizer RSVpreF. In that study, co-administration of Tdap and Pfizer RSVpreF led to a decreased immune response to the pertussis components, meaning that non-inferiority criteria were not met. There has also been a phase 3 study in non-pregnant adults ages 65 years and older on co-administration of RSVpreF and adjuvanted seasonal quadrivalent influenza vaccine. In that study, non-inferiority criteria were met for antibody titers against all 4 influenza strains, as well as RSV A and B. Neither trial had safety concerns. Next. It's important to put these results into context. First, there is no accepted correlate of protection for pertussis vaccination. And in the absence of a correlate of protection, non-inferiority is used to assess immunogenicity of co-administration. However, the clinical significance of failing to meet non-inferiority for pertussis is unclear. And some studies in adolescents and adults looking at Tdap co-administration with other vaccines, including meningococcal and influenza vaccines, have failed to demonstrate non-inferiority against at least one pertussis antibody, but co-administration is still recommended. It's unclear how this might impact protection against pertussis for maternal Tdap when co-administered with RSVpreF, as this depends on transplacental antibody transfer. Next. Additionally, we can look at to see where pregnant people received flu, Tdap, and COVID-19 vaccination. This graph is from the Internet Panel Survey in April 2022. You can see that particularly for Tdap, which is the most similar in dosing timeframe, most pregnant people receive their Tdap vaccination at an OBGYN or midwife's office. Next. This table shows the proportion of practices that offer or administer vaccinations on site to pregnant patients by type of vaccine from a survey of healthcare providers conducted in fall 2022. Responses varied by provider type, and focusing on Tdap again, 73% of family practitioners, 74% of OBGYN practices, and 58% of nurse practitioner or physician assistants offered Tdap on site to pregnant patients. Next. So when asked, is the Pfizer maternal RSVpreF vaccine feasible to implement among pregnant people at 24 through 36 weeks gestation, the majority of the work group answered probably yes, and a substantial minority answered yes. Next. Next is resource use. So you just heard the cost effectiveness analysis, so I'll not repeat that. But in summary, we learned that RSVpreF has the potential to be cost effective with a base incremental cost effectiveness ratio of about $214,000 per quali. And the results are sensitive to a number of factors, including the rate of prematurity, the cost per dose, efficacy, qualis lost, and the timing of vaccination, whether doses are administered year-round or seasonal, such as during June through February. Next. When asked, is Pfizer maternal RSVpreF vaccine use among pregnant people at 24 through 36 weeks gestation a reasonable and efficient allocation of resources, the work group had varied opinions, but the majority answered probably yes. Next. The last domain is equity. This graph shows seasonal population-based rates of RSV-associated hospitalizations among U.S. infants less than 6 months by race and ethnicity during the 2018 to 19 and 2021 to 22 seasons from RSVNet. And you can see that there were differences in hospitalization rates among infants aged less than 6 months old by race and ethnicity across these seasons, but the differences varied by season. Of note, these rates have not been adjusted for RSV testing practices and may underrepresent RSV hospitalization rates. However, this should not affect the distribution of rates by race and ethnicity. Next. And here are the rates of RSV-associated ICU admissions among U.S. infants less than 6 months old by race and ethnicity during those same seasons in RSVNet. And again, these rates have not been adjusted for RSV testing practices. And you can see that population-based ICU admission rates for non-Hispanic Black infants in RSVNet were 1.2 to 1.6 times higher than for non-Hispanic white infants across the 4 seasons. Next. Additionally, multiple studies have shown increased rates of RSV hospitalization among children who are American Indian and Alaska Native compared to the general U.S. population. Shown here is a recent study from the RSV Surveillance in Native American Children and Adults, or SUNA. Highlighted are the seasonal rates of RSV-associated hospitalizations per 1,000 children among 4 American Indian and Alaska Native communities. In these communities, RSV hospitalization rates in infants range from 19 to 112 hospitalizations per 1,000 infants. And these rates were frequently 4 to 10 times higher than the rate in the general population as measured in NVSN, shown in the far right column. This disparity is thought to be due to social determinants of health, such as poor indoor air quality, lack of running water, and household crowding. Next. All ACIP recommended vaccinations are covered without cost sharing for adults in the Affordable Care Act adult group who receive all essential health benefits. Beginning on October 1, 2023, coverage of all approved ACIP recommended adult vaccines and vaccine administration without cost sharing will be mandatory for both Medicaid and the Children's Health Insurance Program under Section 11405 of the Inflation Reduction Act. Currently, most state Medicaid agencies cover at least some ACIP recommended adult immunizations for those not subject to the essential health benefits, but may not cover all recommended vaccines. Next. By federal law, all states provide Medicaid coverage to pregnant women with incomes up to 138% of the federal poverty level. In 2020, 42% of mothers had Medicaid at the time of birth, and about 1 in 9 women of childbearing age was uninsured in the United States. Next. When asked, what would be the impact of the Pfizer maternal RSVpreF vaccine on health equity? The responses from the work group varied, but the majority of the work group answered probably increased. Next. So in summary, regarding use of the Pfizer maternal RSVpreF vaccine to prevent RSV in infants, the work group judged this is an important public health problem and the desirable anticipated effects are moderate to large. The work group was split in judging that the undesirable anticipated effects are small or they don't know. They judged that the target population probably feels that the desirable effects are large relative to the undesirable effects, and that there is probably important uncertainty or variability in how patients value the outcome. That the intervention is or probably is acceptable to key stakeholders. That the intervention is probably a reasonable and efficient allocation of resources, and that the intervention would probably increase health equity. Next. The majority of the work group felt that the desirable consequences probably outweigh undesirable consequences in most settings. However, a substantial minority of the work group felt that there is insufficient evidence to determine the balance of consequences. Next. The majority opinion was in favor of recommending the Pfizer maternal RSV vaccine, but there was a minority opinion to not recommend the intervention. Next. So in summary, the work group overall felt that this is an efficacious vaccine that can prevent RSV lower respiratory tract infection in young infants. However, the work group expressed concern that the Pfizer trial was underpowered to detect a 20% difference in preterm birth. Interpretation of these overarching themes varied. Some members of the work group expressed concern that the data were insufficient to determine the safety of this vaccine. Others stressed that this vaccine can benefit infants by preventing RSV lower respiratory tract infection, and that the difference in preterm births was not statistically significant. Next. The work group discussed several points regarding preterm birth. The imbalance in preterm birth was most prominent in a single country, South Africa. The imbalance in preterm birth was not seen in high-income countries. The imbalance was still present but less pronounced when comparing the prevalence of low birth weight, and most preterm births were more than 30 days after vaccination. Next. The work group also discussed considering a narrower recommended dosing window. Some expressed support for starting dosing at a later gestational age within the 24 through 36-week gestation window used in the trial, as this could mitigate potential risk of early preterm birth until additional safety data are available. Others expressed concern that this could leave preterm infants who are at higher risk of severe RSV disease unprotected. Aligning RSVpreF vaccine dosing during pregnancy with Tdap administration could improve feasibility. And all workgroup members endorsed the importance of post-introduction vaccine safety monitoring through systems such as VAERS and the Vaccine Safety Data Link. Next. The policy question again for ACIP is, should vaccination with Pfizer RSVpreF vaccine be recommended for pregnant people to prevent RSV disease in infants? Next. Before we pause for questions, I would like to provide a quick summary of the proposed clinical considerations for use of the Pfizer RSVpreF vaccine during pregnancy, which are based on the data you have just seen and informed by discussions with the work group. The proposed dosing interval for RSVpreF is 24 through 36 weeks gestation, and healthcare providers could consider aligning RSVpreF vaccine dosing during pregnancy with Tdap administration for feasibility of implementation. RSVpreF vaccine can be administered with other recommended vaccines, such as influenza and COVID-19, without regards to timing including simultaneous vaccination on the same day. Next. For timing of dosing during the year, the work group supported that RSVpreF vaccine should be given to pregnant people during June through February in the continental United States. And healthcare providers can consider offering RSVpreF vaccine year-round for ease of implementation if RSV seasonality is unpredictable and in jurisdictions with different RSV seasonality than the continental US. Next. And regarding giving additional doses in subsequent pregnancies, currently there are no data available on either the efficacy of the first lifetime dose during subsequent pregnancies, nor the safety of additional doses given in subsequent pregnancies. Therefore, the work group felt that it was too early to decide whether additional doses should be given in subsequent pregnancies, and that additional data are needed to inform whether additional dosing in subsequent pregnancies would be indicated, and recommendations could be updated in the future. Next. I'd like to acknowledge my work group co-lead, Dr. Jefferson Jones, and the many others who contributed to this presentation. Next. And after that, I'm happy to take questions.
Thank you very much. This presentation is now open for questions. Dr. Paling.
I want to thank you and the work group for a very clear presentation. I'm going to start with your clinical considerations because the point about what happens to moms who have received this vaccine, because when you've had one child, the likelihood of a second child goes up. And is there any active studies going on? Are they continuing to follow the women who've received the vaccine during the trial? And are we going to get some of that data in the future? Do we know?
I believe we have the sponsor available for question and answers, if it would be all right for them to answer that question. Would someone from Pfizer like to answer that?
This is Iona Majal from Pfizer. Thank you very much for the question. If I can just clarify, do you mean for subsequent pregnancies?
Yes.
Yeah, thank you very much for the question. So we follow all of the women for 6 months after delivery. During that time period, we have noted some secondary pregnancies, and those were summarized in our submission, and we'd be happy to share those with the working group, but they are limited because it's only women who got pregnant in that 6-month period. After that time, the sponsor encourages all the sites, because they are connected to them through the babies, to report any related events, but unrelated events would not be actively solicited by the mothers.
Okay, thank you. And I just want to say it'd be very interesting to understand what happens to their immune response and what happens to subsequent children, if that's feasible. And then...
Thank you very much for the comment. And certainly that is something that we're interested in the post-marketing effectiveness studies as we look forward into multiple pregnancies and subsequent pregnancies. Thank you very much for the comment, and the sponsor will take it under advisement.
Dr. Paling, did you have something else? Or maybe I'll go to Dr. Lehrer and then come back.
Let me defer to my colleagues.
Okay. Dr. Lehrer.
Thank you, and excellent presentation. Could we go to slide 71? I'm very intrigued by the idea of changing the timing of the vaccine, especially as we have a letter from ACOG from Dr. Zahn, who says that ACOG is supportive of the administration of the vaccine, but is suggesting the timing be between 32 and 34 weeks gestation. And I find that intriguing because that would take away early preterm delivery, especially since most of the deliveries that were early were 30 days after the vaccine was given. So I'm wondering if the work group, if you could sort of elaborate on the work group's thinking about that, and also if either ACOG or Ms. Hayes from ACIP could sort of comment on their thoughts on that option. Thank you.
Be happy to talk a little bit. If Dr. Sanchez and Dr. Long want to go afterwards, that would be welcome as well, or other work group members. We did discuss this with the work group, and I'm sorry I can't see you, but we did discuss this with the work group and offered a number of different potential timing of gestation, regarding, changing that window from 24 through 36 weeks gestation to something later, and the answers were all over, they were quite varied. The plurality of the work group landed on 27 through 36 weeks, which aligns with the Tdap dosing administration, but by no means, none of the answers, the choices we gave them landed in a majority opinion. So I think this is something we can continue to discuss in the work group. I don't know, Dr. Long, or one of our work group members wants to add more to that.
Yeah. Oh. Do you want me to?
Go ahead.
Okay.
Go ahead,
No, this was discussed because the concern for prematurity and preterm births was significant in the discussions. But you have to remember that we're preventing RSV, medically attended lower respiratory tract infection, in infants who receive the maternal antibody. So giving it early and having the baby deliver prematurely for whatever reason, that infant or that newborn is not going to get substantial amount of transplacental antibody. So it really would not affect that in terms of the efficacy of preventing lower respiratory tract infections due to RSV. So we really want that pregnancy to go as late as possible so that fetus can get the transplacental antibody. So given it later, it wouldn't matter if that baby, if you had given it at 24 weeks and that baby delivers at 28 weeks, we're not really going to get substantial antibody in that baby 2 months later when that baby goes home. He's not going to have very much antibody left for protection.
I think Dr. Lair's point was that, and I didn't know this about ACOG, and I don't know if we knew that or where you saw that, but anyhow.
The background documents that.
Oh, it was, Dr. Long, I'm outed. I thought I read that background. It would very much abrogate the concern of premature birth because they couldn't be too premature. It's a very narrow window. And as we know with pertussis vaccine, you get better maternal antibody and transplacental passage if you have 4 weeks than if you have 2. 2 is really a minimum. So that would be very late. And what Dr. Sanchez was saying, really, if you hone it down, is this vaccine, in maternal vaccine, would not be protective in prematurely born infants, and that's not a problem. If the baby is born prematurely, not related to the vaccine, but that is not a problem because we're going to have a product for them, and so we're not really thinking that much about having to get it in so early that you would have 2 to 4 weeks before even a premature baby was born. It's a small percentage of the population, and there's another avenue for them. Very likely.
So there are 3 hands raised in the chat from our colleagues from ACNM and ACOG. So I'm going to call on Ms. Hayes first.
Yes, Carol Hayes with the American College of Nurse Midwives. I have a couple of comments and then a question. So one of my comments is I'm just so fascinated by how all over the board the working group was on this. And so I don't know if anybody from the working group wants to comment on that, but I just felt like that it's one of the few times in the many years I've been attending that I didn't really feel like the working group gave us a consensus. So that's just a comment. So I had a question also. Oh, and my other comment was related to that in the states that did not expand Medicaid under the Affordable Care Act, most of them, we don't have very good data on those states. Carolyn Bridges and I went round and round about this for years, that we don't have very much data on whether or not they pay for vaccine administration in adults. And I can tell you in Georgia, they don't. So I'm not getting much Tdap coverage here in Georgia. And then I had a question. I think it was slide 101. If you could go back to that one very quickly.
Is this the slide?
Yes. So I'm curious, the provider type, your source for this is unpublished data, but so I don't see nurse midwives mentioned on there or midwives mentioned on there. And I'm curious if you know the specialty areas of the nurse practitioners and the PAs on whether they were working in pediatrics and primary care or in women's health.
Thank you for that question. I do not know that, but we can follow up with our colleagues at CDC who did this study.
Okay, great. And my last comment is I wish that we had a larger N on some of this data, that we could have a little bit better way to glean out the prematurity risk factor on that. So that's just my only comment. Thank you.
Thank you. Dr. Eckert?
Thank you very much. And I know that there is a background document that ACOG submitted, but just for those who haven't had an opportunity to read it, the highlight was that that ACOG is supportive of administration of a maternal RSV vaccine, given its high efficacy, and also in situations particularly where the monoclonal antibody may not be available. ACOG definitely suggests that or strongly advocates that we need more monitoring post-introduction, and suggested that the optimal time would be between 32 to 34 weeks. But of course, this can be changed depending on data we get and more data down the road about co-administration with Tdap. Mostly also, just for an equity issue, prenatal care happens to more people in various ethnicities across the board. And so it is an opportunity for various ethnicities to receive this prevention method, which has been shown to be efficacious. Over. My other colleague on the phone also may want to comment on this.
Thank you. Dr. Joseph?
Hello, good afternoon, everyone, and thank you so much for the presentations thus far. I wanted to add to what Dr. Eckert said and really emphasize also what she said, and Dr. Hayes has said, has been presented regarding the efficacy of the vaccine, and that ACOG fully supports maternal immunization of RSV during pregnancy. I wanted to address, one, the comment on preterm birth and the concerns that have been raised in the group regarding the signal with the vaccine. And I think, as has been eloquently demonstrated, the 1% absolute difference that is not statistically significant, that the preterm birth rates in the trial were lower than the United States preterm birth rates, and really to emphasize that the trial did include a low-risk population, but when you look at most preterm births in the United States, those are amongst low-risk women. And so if we think about preterm births amongst high-risk women, that's really about 30 to 50%, and really it's amongst low-risk women. And so I think that the safety signal certainly bears post-marketing surveillance, but we would still recommend this vaccination for patients, particularly given the, in some areas, the lack of availability of nirsevimab. I want to also address, you mentioned the question of administration and why ACOG supported a narrow gap. And that was because yesterday there were some discussions on co-administration and how that might affect efficacy of influenza and others in adults. And it's not clear that that data is as strong in the case of maternal immunity. And we know that Tdap is efficacious when given earlier in pregnancy. And if there's any concern about blunting or transplacental antibody transfer efficiency, then it may make more sense to delay that vaccination towards later in pregnancy, especially as there may be a monoclonal antibody option available for preterm infants. And then finally, I just want to emphasize that this is a strategy that will be really efficacious in terms of highlighting equity, as was so really wonderfully addressed in this session. We know that insurance coverage during pregnancy is in the 90th percentile. We know that 80% of patients will obtain early and adequate prenatal care. And we know that patients will have many visits to undergo vaccine counseling with their providers, and midwives are great at this. And so they will have several opportunities to engage in counseling with vaccination, whereas they may not have those same opportunities for their children. And therefore, we can really alleviate the burden on Black and Indigenous infants with regards to RSV.
Thank you. Dr. Talbot?
I can't say the word for the new antibody. Thank you, that's perfect. Is there any benefit of this vaccine over using that, since there's a question about prematurity?
Dr. Jones or Filoni Dutra, do you want to take that?
Well, I got Sarah's shaking her head no, so I think for the record. And then
I was just going to note that Dr. Jones will be talking about this in the combined clinical considerations,
Well,
the relative benefits of both.
when we look at using a vaccine that may have an ill effect, if we have an option B, it makes sense to consider that over option A. All right, and then my second question is, being an adult doctor, are there certain, what? Yes, you are an adult who is a doctor. Yes, but sorry, I'm sorry, it's really hard. Are there certain racial, because you presented some data on racial increased, what's the word I'm looking for? Increased risk of RSV infection, morbidity in certain ethnic groups. In the study, were these groups well represented? Or is this another example of those who should have been enrolled were not?
So just to summarize the second question, the data I presented from RSV Net showed differences between non-Hispanic white infants and non-Hispanic Black infants, as well as infants who are American Indian and Alaska Native. I'm happy to pull this data, but I don't know if the sponsor, would it be all right if the sponsor no, okay, if you give me a second, I'll pull those data. Okay, yes, if the sponsor can respond on the representation overall of those groups within the trial.
I have it from the New England Journal paper. 64% white, 20% Black, 12% Asian, 0.8 multiracial, 1 not reported, race unknown, Hispanic, Latinx, 28%, not Hispanic or Latinx, 70%, American Indian and Alaska Native, 1%, Native Hawaiian, 0.2, and ethnic groups other.
Not perfect, but very well done. So thank you. Very helpful.
Oh.
I think we can move on. Thank you.
As far as, we're going to talk more about it, but as far as, you know, do you need a vaccine when you have concern about potential adverse events? It's a potential signal of an adverse event at the moment. Maybe there's a reason to have 2 products. That would be one.
Can I?
Dr. Cotton may want to add to that.
Just very quickly, I'm part of the work group. I was in favor of later administration of vaccine, at least initially, until we had more safety data. I was concerned about preterm birth. And to answer your question, we did talk about potential for viral escape and that vaccine response might end up being more protective than a monoclonal antibody, but that's hypothetical at this point. But I thought that was of interest to me, Kip.
I have 2 specific questions I wanted to jump in really quickly. One is there a histogram of premature birth by gestational age in weeks? And the reason I ask is because I'm having a hard time with the binary, and I actually would like to see the distribution as a histogram for the placebo and the treatment arm. Is that available, or is anyone able to produce that? Okay.
So at least in the phase 3 study from the New England Journal. Do you have a slide there?
I can, yes, sorry.
If you're able to pull that up, that'd be great. I'd just like to visualize that. That'd be helpful. And then, sorry, can I get my second question out, or do you want to? It'll be easier with the visual for me. You can read it to me, but I won't hear it. So the other question I have is really around, was there any specific sort of differences in the population in South Africa in the trial? And specifically, like, was there concomitant vaccination? I don't know, were there any other differences you can think of that might be related to why? Because it's very unusual for it to be in one site and not consistent across multiple sites.
As far as we know, there were not that we know of. I do want to comment, and while the the Pfizer representative is here, we did bring up why, what was the reason for the preterm births? were they other indications, or their comorbidities? Was it secondary to like preeclampsia? Were they elective? What was the reason? We were questioning that as well. Was that a preterm labor leading to preterm birth, or was it C-section for a maternal indication? So those are still unanswered questions from us. And I did want to say that whoever commented on the, how the work group seemed a little bit less consensus, absolutely. Even from my own standpoint, I've been fluctuating as to whether to recommend it as a shared decision-making. I think Dr. Talbot's point about nirsevimab cannot be ignored either. So it's been a really difficult trying to achieve consensus, even in my own mind. And I think that was reflected. Because, even if they were late preterm infants do have substantial morbidity and higher mortality than a full-term infant. And so we have to take that into consideration. It's not just the 24, 26-weeker.
Regarding the histogram, I apologize, we do not have that. This slide shows those that are late preterm versus all preterm births. But I can give you the numbers verbally. So in the, it's not by histogram, but by buckets, but from 24 to less than 27 weeks, there was 1 preterm birth in the vaccine arm and 1 in the placebo arm, so both of those were less than 0.1%. From 28 to less than 34 weeks, it was 20 preterm births in the vaccinated arm, which is 0.6%, versus 11 in the placebo arm, which is 0.3%, and then the numbers from 34 to less than 37 weeks are displayed up there.
Thank you. Oh, thanks. Thank you. Dr. Paling.
As we are sitting here grappling with this important discussion, I'm also thinking that if you vaccinate a pregnant person, there are 2 benefits. There's active transport to the infants across the placenta, but there's also maternal antibody in the breast milk. And so do we know anything about the breastfeeding and the benefits from the breast milk?
We're happy for Pfizer to comment, but we have not received data on effects of breastfeeding or amount of antibody in the breast milk among recipients of the vaccine.
Thank you very much. Ayuna Manjal from Pfizer. Regarding the breastfeeding and the quantity in the breast milk, we did not actually do breast milk quantities during the study. We wanted to integrate with care and make sure that we limited the number of visits to only those that were absolutely necessary, but we do realize the importance of this data. And so we did collect the data by report, both in terms of breastfeeding and in terms of exclusive breastfeeding in different countries and regions, and did not see an effect on vaccine efficacy related to this. In regards to your questions on differences in South Africa, if the committee would like, I can respond on differences and what we saw in the premature analyses for that country, or we can share it with the working group offline.
Thank you. That would be very helpful. Oh, wait, one more question? Okay, there's a lot of questions. Let's keep going. It's Dr. Paling, Dr. Brooks, and then not Dr. Sanchez. We're good there.
May I thank you for that data. Could you share what was the breastfeeding rate among the RSV and the placebo group in the United States? Thank you.
Thank you. I'll get that data and get that back to the working group. I don't have that at hand right now, but I'll certainly get that and share that with you back to the working group.
Thank you, Dr. Brooks.
On the deck that we have at slide 22, But it's the slide that shows the time from vaccination to birth among preterm and term. And I wish I had it by your number. But what it shows, and I just want to make sure I'm interpreting the slide correctly. It's not this slide. But what the slide shows is that the risk of preterm birth was 30 days or more after, one more back there. So am I looking at it appropriately and seeing that for less than 7 and 7 to less than 30, there is no signal for premature birth? So that's really relevant to me, which means it's only happening as a signal greater than a month after vaccination. Then you also show the slide that from 28 to 32 weeks is the highest, I'll call it efficacy, I'm not sure if that's the proper term, but immunologic response. And then the second highest was from 32 to 36. So to me, this vaccine is the most appropriate given the furthest, the closest to 36 weeks. There was a statement made with nirsevimab, if you have a 29-weeker, then you could utilize that. Dr. Sanchez made a valid point that even if a baby's born at 34 weeks, they're still at higher rate of issues as a late preterm. But that being stated, I would feel pretty comfortable, although we haven't seen, we've seen the evidence, but we're not voting today, that this vaccine is pretty safe relative to prematurity if given later in gestation. And I guess also is that 30 to greater than 30 days with that difference of 58% versus 60% of the total premature births, is that p-value acceptable? Or is that powered correctly or appropriately? That's statistically significant, in other words.
Your question is it statistically significant after 30 days?
Yeah.
I don't know. The confidence intervals were not provided for those.
And that would be what it would be. Yeah. So it really shows clearly that the later you give this, seemingly the safer it is relative to prematurity and more efficacious.
Thank you. I just want to ask, since this will be a decision at some point soon, is there any other information our committee members would like to see from the work group or from the manufacturers that would be helpful for decision making? Dr. Lair.
So to follow up with Dr. Brooks, there's benefits to delay. There's benefits to making the babies come out later. So avoiding preterm birth. There's drawbacks if you don't get the placental antibodies to the babies. And there's going to be a trade-off there. And if someone could delineate that trade-off, I'm trying to write notes to myself, but if someone could do a better job delineating the trade-offs next time when they present it, that would be lovely.
Excellent, thank you. Dr. Paling?
Yeah, I agree with that. I think it's really important, as I take care of a lot of families of newborns, the frequency of prenatal care varies. And so we do need to think closely about the equity, and be a really restrictive time frame may exclude a lot of patients that would benefit. And so we're going to have to pay attention to that. I would also really like to understand the breastfeeding by race and ethnicity as well. And so I just wanted to add that.
Yeah, and I'm going to just add that seeing the safety data with regard to race and ethnicity would be really helpful. We know that there are disparities in maternal mortality. So if there's any differences in the populations that are that could explain, and also just any comorbidities, concomitant vaccines, any of the information that can be obtained from the trial would be incredibly helpful to understand, and how it is by site would be very useful. Anything else from our committee members? Ms. Hayes, do you have any, Dr. Long, and then Ms. Hayes, and then we have to move on.
Dr. Sanchez was reminding me and the obstetricians told us that they would really like to know the reason for the preterm births. Were they typical preterm birth reasons, preeclampsia, et cetera, or were they idiopathic? Idiopathic would be of much more concern to us. And I think we have asked for this, and we have not received such information. Is that correct?
Well, that would be incredibly helpful. Basically, any information we could have to better understand the true safety profile would be really useful for this decision. Ms. Hayes, and then we'll move on.
Yes, I would like to see very specific data on other types of adverse pregnancy outcomes in addition to the preterm birth causes. So if there were congenital anomalies, anything else like that, any more data. Thank you very much.
Thank you for that addition. Next, we will move on to the next talk. It's Dr. Hutton again, who will be speaking about the combined use of Pfizer, maternal RSVpreF vaccine, and nirsevimab.
Thank you. So this presentation is a little different. It's about the economics of the combined use of the Pfizer maternal PrEF vaccine and nirsevimab. Next slide. Again, this is the same research team you've seen before. Next slide. And no conflicts of interest. Next slide. Okay, so our purpose here is to look at the cost effectiveness of nirsevimab and RSVpreF together. So this is the cost effectiveness of nirsevimab in children born to mothers who received RSVpreF at least 2 weeks prior to delivery. But we also want to look at RSVpreF for pregnant persons who definitely will get nirsevimab to their newborns when born or at the appropriate time period. So in this presentation, we're going to look at the results slightly different from the previous one. I was looking at results for every 1,000 individuals born. Here in this presentation, we'll really focus on the results for a single individual. We'll look at results by month of year and the timing of when these interventions are delivered. We're taking a societal perspective over one season with a lifetime analytic horizon, however, and discounting results by 3% each year. Next slide. So in my earlier presentation, I focused on RSVpreF, but I also want to highlight some changes to the analysis of nirsevimab since my presentation in February. Since then, we've made several changes and additions to that nirsevimab analysis. The first of which is that the nirsevimab cost per dose has been increased to $500 per dose, which is more in line with what the manufacturer is talking about. In our base case now, we're also assuming nirsevimab reduces palivizumab use. We also assume that RSVpreF does not change palivizumab use, however. And in our new analysis, our new base case incremental cost effectiveness ratio comparing nirsevimab to natural history, so it's nirsevimab alone compared to natural history alone, is now $157,000 per quality adjusted life year gain. So it's a slight change. Those are some of the slight changes since the analysis in February. Next slide. So I want to really highlight in this analysis, we do not have evidence of efficacy of the combined use of these products. So this analysis is going to be based on some assumptions about what that combined efficacy in both products together might look like in combination. So our assumption here in this analysis is that efficacy is equal to the highest of whatever is either nirsevimab or RSVpreF would be at that point in time. So the efficacy would not be higher than that from the most effective product at that time. Next slide. Just to make this a little more clear, here's a visual example of if nirsevimab is given at birth and RSVpreF efficacy has its highest efficacy also at birth. So both of these things would be at birth, or we'd see that efficacy right at month 0, right at the end at birth. The blue dotted line is the RSVpreF efficacy, and the orange dotted line is nirsevimab. So what we would do in this case is take the upper of these two lines. So the gray line here would be the efficacy from getting both. Next slide. So now I really want to focus, the first part here is focus on the incremental benefit of adding nirsevimab on top of to an infant who already has some protection from RSVpreF. Next slide. So the additional benefit of nirsevimab on top of RSVpreF would look something like this. In this illustrative diagram, we're showing effectiveness of if nirsevimab is given at birth. So the incremental benefit of giving nirsevimab on top of RSVpreF is shown in the gray hatched area. That's the additional benefit you're giving above and beyond the effectiveness of RSVpreF, of giving nirsevimab on top of that. However, next slide, the incremental benefit is going to be different potentially at different times of the year. So in this graph here, in this diagram, if a child is born off peak, let's say in August, then the benefit of adding nirsevimab on top of RSVpreF would be this new gray area here where it bumps up because RSVpreF would have some higher efficacy in August, at birth, but then nirsevimab would be given in this example in October. So you'd see the bump up in efficacy when nirsevimab were given. So I just want to highlight that we have different benefits if nirsevimab is given at different times of the year from RSVpreF. So this depends on when the children are born at different times of the year. Next slide. I just want to remind you that RSV is highly seasonal. Most infections are occurring November through March, but also the risk of hospitalization can be highest in the earliest moments of life or months of life. And so we're taking all those things into consideration here. Next slide. So this next graph shows the preliminary results of the incremental cost effectiveness ratio of adding nirsevimab to an infant who already has protection from RSVpreF, but for different months of birth throughout the year. You can see it changes slightly depending on the month of birth, but it's never lower than $350,000 per quality adjusted life year gain, and sometimes over $1 million per quality adjusted life year gain. Just to explain how these numbers can vary from month to month, let's think of examples of infants born in March and April. An infant born in March would receive nirsevimab at birth, but they would already have had some high RSVpreF protection, so there's a smaller increase in protection for those children born in March. And it's going to provide protection mainly during that off-peak time period following March. But an infant born in April would have protection from RSVpreF at birth, but then receive nirsevimab at the start of the RSV season in October or November, and would receive a higher marginal kind of bump up in their protection, and also that protection would occur during the peak of that season. I also want to note that these incremental cost effectiveness ratios are higher than the nirsevimab only incremental cost effectiveness ratios I showed a few slides ago, because that nirsevimab only cost effectiveness ratios a few slides ago are a mix of nirsevimab provided during peak and off-peak time periods. And more importantly, the previous nirsevimab only or nirsevimab cost effectiveness ratio I showed a few slides ago is the incremental cost effectiveness ratio compared to no baseline immunity of nirsevimab compared to no baseline immunity, whereas this slide is showing the benefits of adding nirsevimab on top of an infant who already has some pre-existing baseline immunity from RSVpreF. Okay, in the next slide, we'll show some results showing if the policy is conducted year-round. So if we add nirsevimab to infants born to vaccinated mothers throughout the year, these are the number of additional events averted per outcome per birth because of the addition of nirsevimab on top of what would have already been prevented from RSVpreF. Notice these are quite small numbers of events per birth because a lot of these events would already have been averted from RSVpreF. The graph shows the marginal benefit of adding nirsevimab on top of RSVpreF. On the next slide, we have the numbers needed to immunize on the next slide. So these are the number needed to immunize with nirsevimab to avoid a particular event, assuming the infants would already have protection from RSVpreF. So this is that marginal benefit here. Here you notice that you'd have to give nirsevimab to a lot of children to avoid things like inpatient visits, again, if they already have protection from RSVpreF. So these are the number needed to immunize on top of the children who already have RSVpreF. Next slide. If we give nirsevimab to infants born throughout the year who already had RSVpreF, we'd be spending $668,000 per quality adjusted life year. Again, if we're adding nirsevimab on top of RSVpreF. On the next slide, we can look at a scenario where nirsevimab is given only to children only born during certain months of the year. So in this next slide, we start to answer the question, what if we only gave nirsevimab to infants born off-peak? So infants would start with RSVpreF protection during the off-peak period and then get nirsevimab in October and November so that nirsevimab would provide protection during that peak of that season. In this case, we do have more additional events averted per child who's been given nirsevimab. And the next slide, we can see the number needed to immunize to avoid one of these events is lower if we give nirsevimab only to these children born off-peak and give it nirsevimab at the October-November timeframe. So in the next slide, if you give nirsevimab in October and November only to those infants born off-peak, the incremental cost effectiveness ratio drops down to $486,000 per quality adjusted life year or so. Although it has dropped, the incremental cost effectiveness ratio is still kind of high. Next slide. So in summary, the marginal additional benefit of adding nirsevimab on top of protection already provided from RSVpreF is small. The incremental cost effectiveness ratio is high when adding nirsevimab on top of someone who's already received RSVpreF protection. Next slide. Now I want to look at the incremental benefit of adding RSVpreF to infants who already will receive nirsevimab. So in this scenario, we're asking, what if we start a policy where all infants are given nirsevimab and then decide to make a recommendation to give RSVpreF in addition to nirsevimab? So this graph shows the effectiveness if the child's given nirsevimab at birth and during the peak, and we can see very little additional effectiveness of RSVpreF according to our assumptions. But the next slide is more interesting. The next slide shows what happens if an infant is born off peak. In this case, there's potentially some greater benefit. In this example, if the child's born off peak in August, for example, they'd have protection from RSVpreF in August and September, and then they might get a dose of nirsevimab in October. Next slide. So here are the incremental cost-effectiveness ratio results of adding RSVpreF on top of nirsevimab. Here, it's very expensive to give RSVpreF to infants who will already be receiving nirsevimab. We're already planning on giving your children nirsevimab. And so the best cost-effectiveness ratio here that we'd see would be for children born in April, but even then, it's about $3 million per quality-adjusted life year gained. In many months, the incremental cost-effectiveness ratio exceeds $10 million per quality-adjusted life year. Next slide. So in summary, here looking at adding RSVpreF on top of nirsevimab, the incremental benefit of adding RSVpreF on top of a policy where everyone's already receiving nirsevimab, the benefit of adding RSVpreF on top of nirsevimab is very marginal. The incremental cost-effectiveness ratio is very high. Next slide. I want to mention a very important limitation. This is, of course, based on assumptions about efficacy with these two products in combination, but we have no real-world trial data about efficacy for the combinations of these products. However, with the assumptions we've made, the combinations of both RSVpreF and nirsevimab add very small additional effectiveness and have very high cost-effectiveness ratio, so it may not be cost-effective to do both at the same time. From the previous presentations on RSVpreF compared to natural history and nirsevimab compared to natural history, it may be cost-effective to do one or the other, but again, from these results, it's probably not cost-effective to do both at the same time. Next slide. So I want to thank you again, and I'm happy to answer any questions.
Thank you, Dr. Hutton. Dr. Paling.
Dr. Hutton, thank you. That was a very convincing presentation. I appreciate the looking at both and saw the eye-popping cost redundancy, and that didn't improve health. So that was really important. I've been struggling with the presentations that we've had, and I would appreciate some perspective. If I am understanding this, both products are highly effective, and the cost of RSV and the burden is high in the infants. And despite that, the cost per quality is $157,000 if I'm looking at nirsevimab, and it's over $214 if I'm looking at the vaccine. That is shocking that it is not cost saving to me. Am I missing something?
I think your understanding of it is correct. A little over $150,000 per quality for nirsevimab compared to natural history. Over $200,000 per quality RSVpreF compared to natural history. Yeah, those are the cost-effectiveness ratios we got. You're right; it is not cost saving. These vaccines are effective, but they're not 100% effective. And I guess for both of them too, the evidence we have is based on lower respiratory tract infections, and so we're looking at the impact of averting those outcomes. A lot of RSV burden is upper respiratory tract infections as well. In these analyses, we're not assuming that there's any effect on upper respiratory tract infections. So in some ways, that might be limiting the value seen from both these products. But you're right that those are our main conclusions, and you're right. Our conclusions are that it is not. Neither of the products are cost saving.
Thank you. Any additional questions? One thing, it's just a comment, and The medical costs look typical and in line with most of the medical costs that we see, and I recognize these are costs and not charges for most of our economic analyses. But I will say, now that I'm in a different role, I have a much greater understanding of the true cost of care, and I wonder sometimes if our models don't keep pace with the way medical costs have really grown. So I don't know if there's anything in the field that would suggest whether or not the costs that are listed, again, which I recognize are intended to be true costs and not charges, are in line with what it costs today. Because I can tell you, if I go to the ER now, I wish it cost that much there. But I'm just having a hard time with this in general. It's not, and again, I recognize this is well established and very consistent with other analyses. So it's not a critique, but I don't know, Dr. Hutton, if you're aware of anything in the field that might reflect where it feels like medical costs are going, at least at a local level in the Bay Area.
Yeah, well, certainly, I think you've touched on a couple of things. One is kind of the rise in cost, and then another thing here is the difference between what we're calling our costs and then medical charges. I think, in the world of, I'll address the second first. In the world of kind of health economics, there is a real concern that charges, what you see on the bill, are very disconnected from the reality of what the real costs are, and also what the payers actually pay. I mean, I teach a class on cost effectiveness analysis, and I show, the hospital bills for my children's births, and the charges are, double what the insurer actually paid. And oftentimes, again, the charges are not really closely related to reality. So we do avoid using charges because those are kind of eye-popping, but oftentimes, especially if you have insurance, you're not actually paying those high costs. But the other thing you pointed to, though, is really inflation. And we've seen costs rise substantially over many decades. And that is something we try to take into account. We are doing some inflation adjusting, taking, what we think are good estimate. The data we get this on costs is a few years old, and we do try to do inflation adjusting. And costs are certainly rising, and we're trying to take that into account. There's possibly some error in that. I will say, finally, we've done some sensitivity analysis based on the costs, and it doesn't seem to substantially change our cost effectiveness results, however.
Thank you. I don't see any other hands raised. So Dr. Hutton, thank you again very much. I'm hoping this is your last presentation so you can go and relax for the rest of the day. So I think our final presentation of the day is Dr. Jones, who will be providing clinical considerations for RSV maternal vaccine and nirsevimab. And again, I'm just going to remind the committee members that it'll be really great if we can hone in on what are the key questions we're going to need for decision making. So as you're listening to Dr. Jones's presentation, please address those.
All right, good afternoon. Next. So there are 3 policy questions that the work group is considering and ACIP might be voting on pending FDA licensure. The first is related to the maternal vaccine. Should vaccination with Pfizer RSVpreF vaccine be recommended for pregnant people to prevent RSV disease in infants? And the other 2 are related to nirsevimab. Should 1 dose of nirsevimab be recommended for infants born during or entering their first RSV season and less than 8 months of age at time of immunization? And should 1 dose of nirsevimab be recommended for children who are at increased risk of severe RSV disease entering their second RSV season and less than 20 months of age at time of immunization? If both the maternal RSVpreF vaccine and nirsevimab are approved by FDA and recommended by ACIP, there may be important clinical considerations for use of both products. Next. So I'll review some of the advantages first of each RSV prevention product. So first, there are potential advantages of a maternal vaccination versus a monoclonal antibody. A maternal vaccine may be lower in price. Although the final prices are not known, manufacturer cost-effectiveness models submitted to CDC assumed a price of $500 for nirsevimab and $200 for the maternal vaccine. As discussed at the last ACIP meeting, a monoclonal antibody is not a traditional vaccine, and many potential issues exist that may complicate implementation of widespread use of nirsevimab. And these include payment and insurance coverage, incorporation into the vaccine schedule or immunization registries, and safety monitoring. A maternal vaccine provides protection immediately from birth when infants are at the highest risk of severe disease from RSV. And a monoclonal antibody must be timed correctly to provide protection during the RSV season, and atypical RSV transmission may lead to unprotected infants. A maternal vaccine induces a polyclonal antibody response, which should be more resilient to mutations in the F protein of RSV than a monoclonal antibody. Evidence suggests that naturally occurring mutations resulting in nirsevimab resistance are rare, but resistant mutations have been detected. Mutations resulted in poor efficacy of a previous monoclonal antibody product, syncytial. Next. So monoclonal antibodies also have some advantages over maternal vaccination. The most important considerations discussed by the work group was the imbalance of preterm birth in the RSVpreF maternal vaccine trials. There's not a similar concern for nirsevimab because it is given to the infant after birth. There are no head-to-head trials comparing efficacy, but protection from maternal vaccination likely wanes. Nirsevimab has an extended half-life of 68.7 days estimated, compared with an estimated 36 to 38 days for RSV maternal antibodies. Nirsevimab administration can be timed to when an infant is entering the RSV season. Next. Additional potential advantages include protection from maternal vaccination relies on sufficient transplacental transfer of antibodies, which may be reduced in some circumstances. For example, infants born soon after immunization while the pregnant person's immune system is still responding to vaccination, or infants born premature because planned transplacental antibody transfer peaks later in pregnancy. Maternal diseases like HIV infection and placental malaria can also reduce transfer. Maternal vaccine uptake has historically been lower than childhood immunization, and uptake may be lower for an RSV maternal vaccine than a monoclonal antibody. However, it is unclear if pregnant people are willing to accept multiple vaccines during pregnancy. However, note flu vaccine uptake among children is only mildly higher than among pregnant people, and the potential uptake of the maternal RSVpreF vaccine and nirsevimab is unknown. Next. So there are products of both. There are benefits of both products being available. Each product has certain advantages, as discussed, and parental preferences may differ, as suggested by a survey asking pregnant people among product preference if both were available. Survey details were previously discussed in the EtR presentation, but among respondents, 28% preferred only maternal vaccine, 25% preferred only RSV antibody injection, and 38% preferred both. Some populations lack access or do not present for prenatal care, precluding maternal vaccination, and scenarios may exist for which use of both products may be warranted to maximize protection from RSV-associated severe disease. Next slide. When considering whether to give both a maternal vaccine and a monoclonal antibody, giving both products was not found to be cost-effective. Since this was presented just now, the highlights is the cost-effectiveness of giving nirsevimab if the mother had been vaccinated was a little under $670,000 per quality if given to all infants, and approximately $485,000 per quality if given to infants born April to September or months with low transmission. The cost-effectiveness of giving RSVpreF to the mother if nirsevimab will be given to the infant was more than $10 million per quality on average. Next. However, challenges exist if nirsevimab recommendations relate to maternal vaccination status. The mother's vaccination status might be unknown by the healthcare provider of the infant. Transferring documentation of maternal vaccination to the healthcare provider of the infants may be difficult. Although limited maternal healthcare information is available during the birth hospitalization, even less information regarding receipt of prenatal vaccination may be available to the infant primary care providers as an outpatient. Next. Based on these considerations and feedback from the work group, draft clinical considerations were developed should both the RSVpreF maternal vaccine and nirsevimab be licensed by FDA and recommended by ACIP and CDC. So either maternal vaccination with RSVpreF or nirsevimab is recommended to prevent RSV disease, but both products are not recommended for most infants. There are certain scenarios when nirsevimab should be considered, even if the mother has been vaccinated. The risks and benefits of both RSVpreF maternal vaccine and nirsevimab should be considered by the pregnant person and healthcare provider when deciding on maternal vaccination with an RSV vaccine. If the mother is vaccinated, nirsevimab can be considered if the infant is considered to have insufficient protection from vaccine or is at high risk of severe disease. Next. Scenarios to consider administration of nirsevimab when mother has been vaccinated include: first, when receipt of a RSV maternal vaccine is not confirmed by a healthcare record, such as a state immunization registry, a mother's healthcare record or vaccine card, and relying on a self-report on vaccination should be done with caution, as it may be difficult for many people to discern with certainty which vaccine was received during pregnancy. Second, when an infant is born within 14 days of vaccination, the infant may have insufficient antibodies for protection. Third, when the infant is born premature, vaccine-induced antibodies transmitted to the infant may be decreased, and the infant is at increased risk of severe disease because of the prematurity. Fourth, when a healthcare provider, per their clinical judgment, recommends maximizing protection against severe disease from RSV because the infant is at high risk of severe disease. And this is particularly important if the infant is born more than 3 months prior to the peak of RSV season and may have limited protection from maternal vaccination. Next. All right, I'm happy to open it up for discussion.
Thank you. This presentation is now open for questions. Dr. Paling.
Thank you for this presentation and taking care of lots of newborns from high-risk families. I really appreciated the importance of talking about the communication of the vaccine status, because we already have to find the maternal labs, which at times can be really difficult. I believe that we as a nation need to step back and think about a universal immunization registry because it's important for everybody to know, and it's not fair to ask the mom to be the one that has to remember what she did and didn't receive. And that would enable all providers, including the pediatric provider, if there's a universal vaccine registry. And this is the first time where I may choose to have a different course of action depending on what the vaccine was or is not given during pregnancy. Thank you.
Thank you. And just to add on, while we're having large major requests of the system, it would be good to continue to think about expanding pregnancy surveillance, generally speaking. I know we've done a lot of work on that, but it seems in this instance it would be really helpful to just have some information about infections and how they impact preterm delivery in particular. Dr. Lear.
Thank you for this presentation. Can you go to slide 156, please? The last time we spoke about the implementation issues of nirsevimab, discussions were ongoing, and this is bullet point 2. And I know there's lots of things that happen behind the curtain. I'm wondering how optimistic people are that some of these implementation issues will be fixed by the time the vote happens, possibly in 4 months.
There are particular ones you want to ask about, just to be specific.
I think that it would be lovely as a practicing physician to have nirsevimab treated like an immunization from the point of view of schedule, recommendations, insurance coverage, registries. And so if we could somehow magically say that this is considered an immunization, so whoever can comment on that, that would be my wish.
Dr. Romero?
Your $5 will be following this for prompting. Now, I was going to make a comment at the end of this this session, but thank you for serving as my segue. I can comment about coverage. The others, I think, we don't have definitive yet. But you know, you've heard about the coverage for RSVpreF vaccine already. You know, CDC would be strongly in favor of covering nirsevimab under VFC if it met criteria for FDA and the committee for licensing and for policy. So I think that's a plus. With the rest of these other questions will be answered as we go forward. I think that if the committee feels appropriate, I mean, it could be listed under under the schedule, if appropriate, and there would be further discussion on that issue. But
Dr. Cotton.
I would just like to agree with your comment in that with monoclonal antibodies for COVID, they are not actually included in immunization registries. I was told by the EPIC, the healthcare record, that vaccines can't, that immunizations or monoclonal antibodies cannot be included in the vaccine section. So it's unclear where they would go and how that would happen, and that seems like a national decision that should be made. I would also just like to reiterate my prior comment from prior meetings about why we are looking at a monoclonal antibody for RSV, but we decided to not look at monoclonal antibodies for other diseases. So I would ask for clarity from ACIP and CDC leadership on that. Thank you.
So thank you for that question, Dr. Cotton. Clearly, we've been looking at this and talking about it for a long time. And with a number of different monoclonal antibodies under development, and with at least some of them apparently having indications very similar to vaccines, we do believe it's appropriate for ACIP to make recommendations for some of them, which is why we've been talking about nirsevimab all along. We have developed some criteria for products that ACIP will consider, and those include being expected to have population benefit, being feasible to implement within immunization programs, and being expected to have cost that's in the same range as vaccines. And I think one of the issues with the monoclonal antibodies used for prevention of COVID, even when they're being used preventively as opposed to therapeutically, is the need for repeated administration. And I think we're envisioning from an immunization program perspective, we're probably not looking at a need for, every 6 months or every 3 months administration.
And Dr. Romero, just could you clarify, I think in terms of, how can we be helpful? Because I think that there are many of us on this committee that would like to ensure that we are expressing an opinion that would enable the availability and access to this product, and particularly given the implementation characteristics of this would really be in our physician offices, similar to docs giving vaccines in their offices or healthcare delivery systems doing this. Is the classification a federal one? Is that an FDA classification? I'm not sure where the classification sits.
So I will let FDA comment on this more clearly, but I have an answer, but if you have a better answer.
Dr. Meyer? Who is from CDC, by the way?
Hi, this is Sarah Meyer. I'm from the Immunization Services Division. So I think the committee's bringing up some really great points, and it's extremely complicated. I think when these monoclonal antibodies are considered therapeutics on a technical level, and then that sends it down a pathway that makes it more complicated. There's issues related to how the vaccines are coded, which has implications to how it can be entered into an IIS, and different states have different laws. So it's very complicated Dr. Cotton, you brought up issues around, even in the EHRs, and it's those kinds of complications that we acknowledge are going to be a barrier, and we're working very hard to try to mitigate them. So we are working on in our immunization information systems side of the house. We are actively working on solutions. Those do take time. So I think we are, doing our best, but acknowledge all of these concerns and. Hopefully over time can work to improve them.
Thank you. And just to reiterate, it's not only for implementation considerations, it's so we can do that dynamic decision-making process, monitoring the ongoing efficacy and safety of these products, and I think that's relevant for the decision-making piece. Sorry, Dr. Romero, is there anything else you'd like to add? Okay. Any other, Dr. Lair?
And so, two questions, one statement, one question. Right now, if a vaccine is recommended by the ACIP, it gets covered under the ACA. And it would be important to me that nirsevimab, for a whole bunch of equity reasons, also be automatically required by the insurers. You've heard my comments on insurers from before. So if an insurer could opt out of this because it wasn't covered by the ACA, that would bother me. So if there's a way of somehow making that happen. And the second one for Dr. Meyer, is there anything that we can do as a committee that would help you in your search to make this easier for us? Is there some statement that we need to make or something?
Well, I think we always appreciate the committee's advocacy efforts around some of these structural challenges because all of the committee members are highly respected vaccine external experts that, voice carries a lot of weight. I think it's, incumbent on all of us to try to find these practice-based solutions so that when you and other providers are in your clinics, you can get the product, you can administer it, you can get reimbursed, you can track it, all of those things. And so I think I think we are going to work hard on providing materials and resources for education of providers, how they can talk to their patients about these products, how they can help monitor safety of them. So we're going to be doing that, and we always appreciate the committee's feedback, to help us improve the implementation of these.
Thank you. Dr. Sanchez?
Yeah, I just wanted to comment that there is precedence. We document HBIG as well as polyvisumab on immunization records. So this could easily, we do on EPIC. It's in the list. And certainly we know which baby received HBIG. And so I think this could be easily added.
What record is that?
EPIC. And so, but I do think it's going to present more challenges, even under vaccine for children, because we would like to give it even in newborn nurseries. And of course, those are delivery hospitals, general hospitals, not children's hospitals that make this a little bit more difficult. But there will be challenges, but I do think those challenges can be overcome.
Dr. Daly, sorry.
Dr. Lee, you were lost in thought there for a moment. So, Dr. Jones, could you go to slide 161? And this is continuing along this theme, but so it would be helpful for me to discuss two issues. One is the issue that Dr. Sanchez just brought up about use of nirsevimab in hospitals, but maybe we can put that to the side for a second. So I would love to discuss a little bit more how much of a barrier knowledge of maternal vaccination is to the administration of nirsevimab in primary care practice. And I'll put my hat on as a primary care pediatrician, and I would love to hear from the other colleagues, including family medicine, Dr. Lair, but I occasionally am caring for a newborn for whom I do not have maternal records, and that's really hard. But I think we're in an era where we can do everything possible to make sure that doesn't happen. And I need to make sure that this is not just sort of focused on the practice setting that I particularly practice in, because there are settings for much more disadvantaged patients where there's, much more fragmentation of care, and I sort of fully acknowledge that. But I feel like we do everything we can to get the maternal record because there's so many pieces to that record that then influence our care. And we sometimes just call up the nursery and say, I'm seeing this kid today. Can you please tell me these attributes? It doesn't always work, but it works most of the time. So I think we can have a strategy of use of nirsevimab that is, the expectation is what mom's vaccination status is and that's feasible in most but not all settings. I think that's doable, but I want to check with you guys first. Dr. Lair.
I can comment maybe. So I do influenza vaccine effectiveness studies. So we need to know if the adult was immunized or not. I have a full-time staff member who does nothing but track down immunization records. And you think it may be simple if they got it at the grocery store, but they actually have a walk-in clinic and a pharmacist. And sometimes the records are kept on site. Sometimes they're kept at the central location. Sometimes they hire nurse companies that come in to do it seasonally. It is a very difficult task. So that is not unique to what you have seen. COVID has somewhat improved that, because as providers began giving COVID and it was mandated to put into the state immunization registries, some providers said, oh, this isn't so hard as we thought, and have started adding influenza. But we have a very long way to go when it comes to adult immunizations. Thankfully, some states require it, but the majority do not. So I was really upset when it no longer became mandated to put COVID in there, because it really, really helped us out for other vaccines, but it is not unique to you.
Fully granted, although I think hopefully it's better than sort of the Wild West of trying to find adult immunization. I mean, I'm not disagreeing, I'm just saying.
Yeah, I know. Yeah. And it really depends, and I'm hoping some of this is a cultural change, which was initiated with COVID. But it's also not uncommon for adult providers to lose their providers regularly. There's a high turnover. And so it's not uncommon for me to get a patient and they say, yeah, my provider went out of office. Went out and there's no record. So I don't know any of my immunization records. So.
Well, and I think we can do better. But actually, just backing up a little bit, Dr. Jones, thank you. Because, again, you're thinking of, I appreciate the care with which you're thinking about all the different scenarios here, because it's just very helpful for us, and it just puts us in a better place. So thank you. Dr. Sanchez, could you talk to us about the barriers to use of nirsevimab in inpatient nursery, hospitals that care for moms and babies? Because I think that's a piece that we haven't talked about as much.
Yeah, I just think that they're not used, in the newborn nursery, if we do want to give it there before, like if the baby's born in the midst of an RSV, high, epidemic or whatever, during the high season, I think that in 24, 36 hours, that baby would get it. And I think that we're dealing with many times non-pediatric pharmacists. And we will have to work through that to make sure. We give hepatitis V vaccine, we give HBIG if needed, so I think it's going to be just another process that we'll have to make them aware of, and especially if there's more paperwork related to vaccines for children and what have you.
Ms. McNally?
Thank you. I have some degree of discomfort about co-administration with Tdap and RSVpreF for the reason that it led to decreased immune response. So I'm wondering what will be reflected in clinical considerations if this vaccine goes forward. And I'm really, I feel really strongly that moms should be counseled on the fact that we don't know what impact this will have against pertussis, so that they can make the choice to get these at different times if necessary.
So we are encouraging that when the maternal vaccine is considered, that the risks and benefits, and we'll try and provide lots of educational materials on what we see as the risks and benefits of the vaccine and nirsevimab be discussed. In general, CDC doesn't mandate what risks and benefits exactly have to be discussed. We'll have the vaccine information sheet and are working to develop something similar for nirsevimab. And so it'll ultimately be up to the provider what to discuss. And as reflected in our work group, I think there's a variety of opinions on the importance of the decreased immunogenicity of the pertussis component when co-administered. So I think there are different options available as far as not giving the vaccine and deferring to nirsevimab, giving it sequentially, or for those who prefer co-administration as well.
Dr. Long?
Yes, it makes me think a little bit more about something that we have not mentioned yet. The work group will be taking up the vote yesterday on this same vaccine for adults, the only adults for whom it will be recommended. It will be recommended in a restricted kind of way. And I think we favored, if we could, to administer the vaccine, the RSV vaccine, to older adults, not concurrently with other vaccines, unless there was a reason to think you wouldn't be able to get all vaccines in. So how do y'all think? I understand this is a different age group we're talking about, but adults are adults. And the fact that women of childbearing age are less likely to have neuroinflammatory syndromes, to me, doesn't exit the possibility that this could happen in a pregnant woman, the neuroinflammatory.
I think for me, what would be helpful is, and maybe our OB colleagues, this would be intuitive to them, there's a very narrow window to give a bunch of vaccines to pregnant women. And given that there's several on the table, what I would want to know is how to counsel them in terms of risk and benefit. I think of the importance of Tdap vaccination to protect against neonatal pertussis, because even though we're vaccinating kids, we can't get vaccines to them in time to protect the most vulnerable. And similarly, we know the impact that flu can have, and that we can't give vaccines to kids until 6 months of age. So if I'm just going through in my mind and I was counseling a pregnant woman, I might say, if we had to separate those and I have a very short time window, here's how I might think about it. And then I think, to Ms. McNally's point, in many ways, it's no different than the kind of informed consent process. We say you always have an alternative, and here's an alternative. So that does feel like making sure that people are aware of the alternative strategies that are available to them would be helpful. Given that, I just don't know. I just can't imagine if they're not simultaneous. I don't know how we're going to get them all in time. Are there enough visits? I guess they're coming back weekly or biweekly, so it's possible, but it is a tight time window. Dr. Paling.
All right, so I really appreciate this conversation, and thank you for kicking this off. Your point is really well taken, and one of the big things is the amount of things we're putting into your OB visits from an OB provider is increasing, and do we have the codes for them even to be compensated for these complex discussions. And so making sure we've done that. And I very much appreciate, Dr. Sanchez, that you've got HBIG on your EPIC. We don't. And so that makes me think the EHR, we're all customizing it, but really what we need to do is work with the big EPIC EHR providers and have that part of the base so that everybody doesn't have to replicate that. And that would provide more transparency and an increased likelihood that we're going to get the information in a timely way in the pediatric office, as well as during the newborn period when the birth hospitalizations typically are 24 to 36 hours and a lot's going on. Thank you.
Dr. Lear?
I haven't done OB for 15 years, but having said that, 2 of the vaccines are recommended for women during pregnancy. So flu and COVID are just a general recommendation. And so there's not a timetable on that one. Tdap has a wider point of view, 27 to 36 weeks, I think. And if this one might be similar to that, this one might be more narrow. I'm less pessimistic or more optimistic that they can fit these in. Again, assuming that there's people coming to their prenatal visits, which is an equity issue because sometimes people don't come to the prenatal visits. But I do think there's enough space to space out the vaccines. Thank you.
Dr. Bell.
Yes, thank you. Just going back to what Dr. Sanchez and Dr. Daly were talking about, and this may be ancient history, but I just wanted to actually encourage the CDC people, if you haven't already, to talk to the hepatitis people. The perinatal hepatitis B vaccination program, including, getting maternal HBsAg status into the delivery hospital and the issue of HBIG and following infants is something that at least was a pretty well put together program, including involvement of the health department. And it just might be a place to get a little bit more information about how to approach this kind of thing. But I do think that in the case of perinatal hepatitis B, it has been done, and I think it is feasible.
Thank you. Dr. Joseph, I see your hands raised.
Yeah, thank you. I first want to commend the committee on the aspirational requests as far as adult immunization registries and more funding for SETNet. I totally stand behind those efforts. I wanted to circle back to the concerns related to what information might be needed to support ACIP recommendations. And I wanted to underscore that that I think it's really beneficial if we lean towards a universal vaccine strategy, only because when I say ACOG supports, it's that, as has been demonstrated with COVID, that we do provide multiple opportunities to support providers in their counseling provision. And again, we've talked about in this group and others, changing the Tdap vaccine schedule so that it occurs earlier in pregnancy, such that there is plenty of time to provide both RSV and Tdap and other vaccinations that are considered recommended during pregnancy. And certainly, as was alluded to earlier, we can't exclude the maternal RSV vaccination.
Excuse me, Doctor, could you speak a little more into the microphone? We can't really hear you that well, or maybe speak slower. I'm not sure, but we don't have a good audio on you.
Oh, I'm so sorry. No, I think I was essentially saying that certainly ACOG would provide the support along with our colleagues with ACNM and A1 and others to make sure that providers are well or have the tools to support the vaccine strategy during the pregnancy, and that this may provide a more durable option, especially as we don't know where nirsevimab availability will become available. As it stands now, especially when we get to October, we know that the vaccine may be available, may be more readily available, and that we are willing to provide support to our providers to ensure that they are well equipped to provide vaccine counseling and to work with others.
Thank you. I think that would be really helpful to hear from ACOG and ACNM on this issue, given the number of, it's incredible. The number of vaccines that are now available for pregnant women is unbelievable. And we want to make sure that we understand both from an implementation perspective, as well as obviously a recommendation perspective, how to best support it. Dr. Saneas.
Thank you. I actually have a question about safety monitoring for nirsevimab. Should it be approved? Would it be through VAERS?
Hi, this is Tom Schum of Crow. Can you hear me?
Yes, thank you.
So nirsevimab is classified as a drug by FDA, and the system in FDA, and then therefore it falls under CDER for regulatory purposes. And the system they use is called FAERS with an F. So that system would be available to receive spontaneous reports. It's a spontaneous reporting system like VAERS. In VAERS, we are going to be able to capture nirsevimab reports if they are submitted to VAERS and it's a nirsevimab only report. We are going to be able to capture those reports, and we are going to be able to notify our colleagues in CDER that a nirsevimab report came to VAERS and make that information available to them. If nirsevimab is given with other vaccines, that's a vaccine report. And we'll have a process to that's really not that much different than multiple vaccine products being given, which we have the ability to capture in VAERS. In this case, you'd have a vaccine and another drug, which we also have the ability to capture. So we will be monitoring for those reports where co-administration with vaccines occurs, and we will also make those that information available for those VAERS reports to our colleagues in CDER. We also plan to monitor nirsevimab in the vaccine safety data link, similar to how we do for vaccine products. Just want to mention that I think monitoring for nirsevimab will be confounded by co-administration with other vaccines. We anticipate it's going to be given with other vaccines, either at birth or at well-child visits early in infancy. But we deal with that problem for simultaneous administration of other vaccines as well. So there'll be a robust monitoring process in place for nirsevimab to include CDC and FDA in collaboration between the two agencies to make sure that safety information the data are analyzed and are made available to the ACIP work group and to ACIP in a timely manner.
Dr. Daly.
So I have two comments, and first, which would be, and I turn to Dr. Wharton and Dr. Lee, this would be a time to sort of ask for more OB/GYN expertise on ACIP. And would you comment on that? And then I have a question for the work group.
We always try to maintain the optimal balance of expertise on the committee. Sometimes we're more successful than others. But stay tuned as we await with interest the sign-off on our current nominees.
Great, super. And then this one's a harder one, and I apologize. So this is sort of to Dr. Jones and Dr. Fleming-Dutra, but that in the background for me is just to try to understand how concerned I am about the risk of prematurity for the maternal RSV vaccine. And I feel like through today, there are things on the sort of I'm less concerned side of the ledger, and then there's a few things on the I'm more concerned side of the ledger. And generally speaking, actually, I'm kind of a little bit less concerned after hearing additional attributes of the of this. On the more concerned side, though, is this idea that there was also prematurity in another RSV vaccine given to pregnant women. And so is there such a thing as sort of vaccinology or immunology expertise during pregnancy? Is there a biologic plausibility to this that was discussed in the work group, or is that just more a theoretical consideration with a different RSV vaccine? Thank you.
Perhaps I'll start and then hand it over to Dr. Long. We have had long discussions about whether or not there could or is not a biologic plausibility to this. I think in both the GSK trial and, in the GSK trial where the imbalance was statistically significant, the mechanism for that imbalance remains unclear at this time. And I think the work group has struggled with the, we showed you these data because they, have been difficult to interpret. I think in the same way that you're looking, there's more or less concerning pieces to those data. We have asked, as Dr. Long indicated, for summaries of the preterm births that could be reviewed by those with OB expertise that might be helpful. We have not yet received those, but we will continue to ask. I don't know that we have come to a sense of whether or not there is a biologically plausible mechanism, and I think our work group may remain conflicted on different hypotheses. I don't know if Dr. Jones or Dr. Long wants to add to that. I'm sorry if that wasn't a very satisfying answer, but we're struggling.
The only thing I could say is that we have asked GSK to see if they have any data on the vaccine that they halted. And we have not heard anything about that. And I don't know if there is what the biologic plausibility would be, but I don't discount that there could be one. A month is about the time when you've got maximal immunologic responsiveness. What if it cross-reacted with some kind of or caused a vasculopathy in the placenta that made it, have apoptosis earlier, if it atrophied, if it did something else? So you have to wave your hands. We don't know. But you are right. There was a statistically significant occurrence that led to the halting of another vaccine that's very similar to this vaccine. And there's a good bit of angst on the committee about this possibility. We talked, the fact that it's not statistically significant, it's different than saying there may be a trend or there may not be a trend. I mean, it is this close. It is very close to being statistically significant. And so it's just where, where do you hang your hat? I'm sure that the likelihood that this occurred due to chance alone is less than 1 in 10. It's just not 1 in 20. So it is of concern, and that won't go away, and we won't have more data, and we don't have any kind of biologic plausibility.
We have our colleagues from GSK who have raised their hands, so.
I didn't know we had GSK on this line.
Dr. Webster?
Hi, yes, Peggy Webster with GSK. Just sound check that you can hear me.
We can hear you, thank you.
Oh, good, fantastic. We have been puzzled by this as well. We have not identified any type of biologic plausibility that could explain the signal. We've had conversations with the work group. We've shared with them the data that was generated, and that's about all I can say. We just have not found a biological plausibility reason for the statistically significant imbalance that we identified in our phase 3 trial.
May I ask both manufacturers, were the trials done during a time of high RSV circulation or very low RSV circulation?
This is Iona Manjal from Pfizer. I can answer regarding the Pfizer trial.
So we started the trial in June of 2020, and the analysis includes all of the data through September 2022. During that period of time, we saw low rates of RSV during the pandemic, but then we saw 2 very high resurgences of RSV. In regards to the timing relative to RSV outbreaks or COVID outbreaks, we did not notice any clustering of the preterm births. The preterm births, as you summarized nicely in the study, were very low and were limited to select upper middle income countries, where although there was no difference in background factors or causes of prematurity between the RSVpreF or the placebo group, there was a notable trend in those countries to do later gestational ultrasound dating. And so we see a higher discordance in those countries between the gestational ages and actually things like birth weight or more objective measures. What is extremely reassuring when we look through our data is that adverse outcomes related to the prematurity are not seen. For example, we don't see any increase in hospitalization, any change in APGAR scores, and most importantly, no neonatal death increase. In fact, we saw a trend, as you nicely highlighted, of a potential improvement in death outcomes in the study. And we think this is largely due to the cadence of the trial. The vaccinations, although they started very early at 24 weeks, we didn't start to see any aberration in prematurity until clustering right around term. And that leads us to believe that this could be due to a dating issue rather than a true instance of higher prematurity. And that was underscored by the lower differences we saw in low birth weight. Obviously, we'd have to assess this in larger post-marketing studies, and that's where our post-marketing surveillance will come in very useful as we plan this for the rollout. And reassuringly, as you know, in high-income countries, in both the general population and in underrepresented groups, we saw no difference in the rates of prematurity or low birth weight. And that's specific, of course, to our US population.
And this is Peggy Webster again from GSK. Our study ran from 2020 until we identified the signal in February of 2022. When we evaluated our data, we did see temporal clustering that occurred between pretty much the months of August and December of 2021. The signal was more pronounced in low middle income countries than in high income countries. We did look at whether RSV infection could have been a factor in the preterm birth imbalance, and we were unable to find any correlation there. So again, we just have not found a plausible explanation for why we had this temporal clustering, the geographic clustering of the signal.
The number of preterm births in both studies, just numerically, were similar, the total number. And those, the total of the premature birth outcomes of 370 in the Pfizer study, individual patient profiles of all of those infants have been summarized and shared with the working group. And we'd be happy to make that available to the wider committee as well.
Thank you. I think seeing those data would be incredibly helpful for the work group and for the committee. Dr. Sanchez?
I just, while they're on the phone as well, again, and I'm sure you heard, the reason for the prematurity would be really helpful to ascertain. But otherwise, the time period involved, at least for the Pfizer, was during the COVID pandemic. And if I remember, was there any signal there in terms of prematurity and COVID? Or were these women tested during that period?
She said that
there's not, I'm sorry.
So I can answer for GSK. We did look at COVID infections and were unable to find, again, any sort of association between the preterm births and the COVID infection or COVID vaccinations.
And then,
Ayana Majal from Pfizer. So in the Pfizer study, there was also no association between COVID infection Although we in the study did collect outcomes in the mother of rates of medically attended respiratory tract illness, we did not swab all the maternal participants. And so our ability to sort of faithfully capture the reason behind respiratory illnesses in all these participants, particularly those in the upper middle income countries where we saw this difference, may have been underreported. We know from the timing of the COVID outbreaks relative to our prematurity, there was no clustering associated with that.
Thank you. But I think overall, and getting back to Matt's question, I mean, the fact is that at least in the United States, there was no signal towards prematurity. I mean, I'm really torn by that. Because it's a vaccine that we want. It's a vaccine that is needed. RSV, and as you know, in infants is huge, and it's mostly in full-term babies. And so I think that the fact that it wasn't seen in the United States is certainly reassuring. But at the same time, we can't, that other signal is playing a role as well.
Dr. Lear?
So I totally agree with Dr. Long that it was incredibly close to statistically significant, and it bothers me. I'm not a statistician. I'm wondering if it would be appropriate or useful to do a meta-analysis adding the GSK and the Pfizer together, because they're very similar vaccines, to see if that gave us any more information. I don't know if that's appropriate, but I just throw that out there as an idea. Right, I would assume it would be significant, and would that be helpful to the committee to know that when you do a meta-analysis, it's significant? Because it's very close to significant right now. But I also hear Dr. Sanchez's perspective that in higher income countries like the United States, it was not significant.
Sorry, go ahead, Dr.
But we
Long.
have to remember that it wasn't adequately powered. It was not powered to detect even a 20% difference. So what we really have is really a signal, inadequate rejection of the signal because of sample size, not because, it may not be associated, but inadequate study.
I mean, the other reason that these safety data are so important is I'm realizing that the trials enrolled healthier women who are probably at lower risk for complications like preterm delivery. So as a risk mitigation, using that perspective, I might think about how would we tailor the recommendation to ensure we are minimizing exposure of the vaccine to women who might already be at risk for preterm delivery, as an example. But I don't know, presumably that would be one potential criterion. I would want to know if there are other things that are emerging from the safety signal that could be helpful to mitigate risk in some way.
Although my concern with that is, I have a feeling that the same mothers who are predisposed to have premature babies, those babies are at higher risk to have comorbidity from RSV. And so how do you, don't give the vaccine to the mom whose baby's at highest risk seems kind of dangerous.
Well, unless you can give nirsevimab. I mean, so I think, so that's why I'm trying to figure out how can we make sure that the mom and the baby are optimally protected. Dr. Daly?
Yeah, I mean, I think, so Dr. Sanchez, I'm trying to find words for what you described, and I'm not sure I know what those are. It's not exactly heterogeneity of treatment effect, but it's a similar concept, which is to say, this safety signal could be due to chance alone, or there could be risk factors, and that would actually go along with that it was found in low and middle income countries and not in high income countries, if there's sort of risk factors for prematurity that were in those women, those patients in low and middle income countries. And then the problem, and this problem comes up in safety surveillance, is if there's a a particular group who's at risk, and then you do stratified safety analysis, then you lose all your power, essentially. And then if you lump it all together, then you don't see the safety, because the safety concern is not distributed evenly across the population. So I think that's part of the challenge here. Again, I think we all have this observation that we have some concern. There are some reassuring things. And are there risk factors for an adverse event from this vaccine that somehow relate to risk factors for prematurity as well? And that's going to be pretty tough to tease out. I mean, I suppose that's, if we want challenges, there you go. But I don't know, Dr. Fleming-Dutra or Dr. Jones, if that is part of the work group, or Dr. Long, part of the work group thinking about how to think about this safety signal is related to that risk. There may be certain populations that are at risk if it's a true adverse event, and then we recognize it could be not true.
One of the, we thought of a few things that could, at least early on, mitigate, and one is not offering it 26 or 24 weeks, but 27 to 36. I just don't think 32 to 34 would work. You'd miss it, and then they would be unprotected, and it would be a problem for equity as well. The other one was not to offer this year-round when you could not benefit. Your baby could not benefit from this if you got it in certain months and the baby was born at term. So then you just have risk. You don't have possible benefit. You just have risk. Those are the two things that we thought about. But I do believe that the other big one would be, it should only be with shared decision-making with the data that we have available. And although that would be unpopular, that will be what we will discuss, since that's what we came down to with adult recommendation of the same vaccine.
Thank you, Dr. Long. It sounds like you have your work cut out for you with the work group. So we're going to end there. I want to thank everybody for a really thoughtful session and appreciate all of the presenters. I want to thank them. And we will take a break and return in approximately 10 to 12 minutes for public comment. Thank you, everyone.